Good morning, everyone. Welcome to the third annual Pharmacogenomics Symposium at Washington University in St. Louis virtually. I'm Patty Dixon. I am a medical geneticist here at Washington University. This is a Zoom webinar. It's being recorded. There will be the ability to put questions. Oh, I'm echoing. Is it any better or is it this continuing?
Dr. Dixon, I'm not hearing an echo.
I don't hear an echo.
Okay. Okay, I'm sorry about that. There will be the ability to put questions in either the chat or the Q&A. You might not see each other's questions or in the chat or the Q&A and can't chat to each other or unmute, but you should be able, we will be able to see your questions. The panelists will be able to see it, and we will answer questions at the end of each talk if there's time, or at the end of the session if there's not time. So, the idea and practice of tailoring medication dose and choice to a patient's genotype is not new. There have been examples of pharmacogenetics with specific gene-drug pairs that have been part of mainstream healthcare for a long time. But to truly deliver on the promise of pharmacogenomics requires massive data collection and population sequencing efforts, data sharing, and ways to analyze these data that are starting to evolve rapidly only of late. It's a very exciting time to work in genomics and in medicine, and I'm very excited to see what the field holds for the future. So to that end, today our organizing committee has lined up a terrific group of speakers for today's symposium. Again, for those of you who are just joining us during this Zoom webinar, we ask that you put your questions in the Q&A or the chat, and the panelists will be able to see your questions and answer them either at the end of each talk if there's time, or during the at the end of each session before the breaks. So there's the agenda there. We can go ahead and get started, I think, with our first speaker, who I'll introduce. So we are very pleased to welcome Dr. Andrea Gaedic. She is a professor at UMKC School of Medicine, Director of the Pharmacogenomics Laboratory, Division of Clinical Pharmacology, Toxicology, and Therapeutic Innovation at Children's Mercy Research Institute. Thank you, Dr. Gaedic.
You're on mute, Andrea.
Now. So you can see my slides right now?
Yes, we can see your slides and we can hear you.
Okay, thank you so much again. So foremost, again, thank you so much for inviting me to be a part of this wonderful panel in this conference this morning. So it is a pleasure to start this series and tell you more about PharmVar, nomenclature of pharmacogenes, and more. So the objectives of my presentation this morning is to understand more about how variation in pharmacogenes contributes to drug metabolism and ultimately drug response. And then also to introduce and tell you more about the star allele nomenclature, which is widely used in the field of pharmacogenomics, and learn more about the PharmVar consortium and database. And I do not have any financial conflicts of interest. So traditional versus precision medicine approach, the audience might be familiar with this, but I thought I'd just give a very brief overview. So the standard approach that has been used and is still standard practice in many institutions is to a one-size-fits-all approach where every patient receives the same fixed dose, despite our increasing knowledge that genetics really is making a difference in how people metabolize and react to drugs along an entire series of other factors. And so precision medicine approaches increasingly use especially genomics to stratify individuals into groups and then make a decision whether a lower or increased dose is more appropriate for a given patient or whether an alternative drug should be used altogether. And the overarching goal is to really minimize adverse events if in cases the patient has trouble metabolizing the drug accordingly, to minimize adverse reactions and also avoid a non-response. Pharmacogenes are highly polymorphic. No matter what pharmacogene you look at, there is a wide range of activity in a population, not only within a population, but also across populations. And in this graph, which represents urinary metabolic ratios of CYP2D6, you can easily see the broad range of activity where on one end of the distribution, you have these ultra-rapid metabolizers. On the other end of the activity distribution, you have these poor metabolizers. And then in between, you have those which are classified as intermediate metabolizers and these normal metabolizers. And CYP2D6 is one of the most prominent pharmacogenes which metabolizes over 20% of clinically used drugs, among them antidepressants and antipsychotics, but also opioids, which are used in pain treatment. And I'm sure we will hear more about 2D6 by Kristen in the next talk. Now, no matter which drug metabolizing enzyme you are really looking at, there is a broad distribution of activity. And for all of those, you will find individuals with very little or no activity and extremely high activity. And as these examples here show you, these drugs metabolized by these genes really come from different drug classes. And we will also hear more about DPYD and TPMT, especially later on in the talks. In this slide, I really just want to highlight that the prevalence of altered cytochrome P450 phenotypes, but also the phenotypes of other drug metabolizing enzymes, really varies dramatically across population groups. So you can see just by the height of the bars, the proportion of non-normal metabolizers in these world populations and the enormous differences. So for CYP2D6, which I'm circling here, the differences might not be all that pronounced, but you can see that between 30 and about 60% of individuals in a population have non-normal phenotypes. And for CYP3A5, for example, the differences among populations is even greater, between about 14 and 73%. So variation in pharmacogenes is not a rare event. This really affects almost every person in every population. And that has been also very nicely demonstrated in a publication that came out about 6 weeks ago that clearly shows that adverse drug reactions are indeed preventable. So this was a European study that used a 12-gene pharmacogenetics panel. They worked with a variety of European populations. And the take-home message from this study was that PGX-guided prescribing resulted in a 30% reduction of clinically relevant adverse drug reactions. And the percentage of preventable adverse events could even be maximized by testing, for example, more variants of a panel and more genes. So this is really just, I want to say, still the tip of the iceberg of what can be done with pharmacogenomics. Also in this study, and this really goes along other published literature, is that 94% of patients tested with this panel had at least one actionable variant. And 45% of these patients had an actionable variant in CYP2D6. So I think it is easy to imagine that pharmacogenetics can potentially really affect each and every person, because as we are growing older, especially, we are taking medications, more medications, and no matter where your variants are, there is a good chance that you will take a medication at some point in your life that is affected by a variant in a pharmacogene. Now, I would like to introduce you to Ben and explain variation for this particular patient. So Ben sequence is, or a part of Ben's CYP2D6 sequence is actually on the front of our research building here in Kansas City. You probably recognize these Sanger sequencing traces, and part of Ben's sequence sits right here. And he was chosen because he is really a wonderful example to present on and highlight some of these challenges, but also possible success stories in pharmacogenetics. So he was a teenager when he was prescribed atomoxetine, which is also known under the brand name Strattera, to treat his ADHD, which is not uncommon in children and teenagers. And he eventually experienced a racing heart rate, which was really scary for him. He was, however, not sure, was it the drug he was starting to take recently, or was it really just anxiety because of his finals? But it was a really scary moment. And so he went back to his physician, who lowered the dose, and he was then actually doing quite well. The adverse reactions subsided. The drug was still given at a high enough dose to really allow him to manage his ADHD. Now, we were lucky that Ben was also part of a research study, and actually multiple research studies over his lifetime. And that allowed us to learn more about his genetic profile. So Ben had an adverse drug reaction, which resolved upon lowering the dose. He was also in that research study genotyped for 2D6, and a first pass of testing revealed that he had a CYP2D6 star2 star4 genotype. Now, what does that mean? The star2 allele is believed to be a normal function gene. The star4 is a reduced function allele. So that gives rise to an activity score of 1. If an individual has 2 fully functional alleles, the score is 2. So he has 1 functional, 1 non-functional activity score of 1 that classifies him as an intermediate metabolizer. Now, later on in the study, we added testing for some rare alleles, and long and behold, he revealed, or it was revealed, that he had a fairly rare variant that is part of the star 59 haplotype. So that means there was one additional SNP discovered that changed the star 2 assignment to a star 51, which is right now categorized as a decreased function allele. So that lowers his activity score to 0.5, but still classifies him as an intermediate metabolizer. Now, his pharmacokinetic profile, or the area under the curve, indicated, however, that he was more like a poor metabolizer. And I want to show this in Okay, here we go. In this graph where we compared his AUC to other study participants or study participant of a prior study. So first of all, for atomoxetine, the PK profile for these intermediate metabolizers with an activity score of 1 was not statistically significantly different from normal metabolizers with 2 fully functional alleles. However, individuals with a score of 0.5 as his revised genotype, these were clearly different. But how Ben really presented in the pharmacokinetic study was more like a poor metabolizer. So this really teaches us 2 things. First of all is where alleles could have an impact, and if they are not tested for, one might miss out on really important information. And many commercially available pharmacogenetic test panels do not test for this star59 allele. The second challenge is that there are still so many CYP2D6 allelic variants out there for which function is either uncertain, unknown, or just not enough information to really get this classification right. And that star51 is one of those alleles where we need more data to come up with a better, more accurate function classification, as these data indicate this might be a dramatically reduced function allele or even possibly a non-function allele. There might also, of course, be substrate-specific differences for the function of these alleles. So there is still a lot we have to learn about 2D6, the impact of genetic variation on function to get it right for every person. Now, what could have been different if the genotype for Ben would have been known before he started his medication? And this is where the CP guidelines really come in. So these are guidelines that are published by the Clinical Pharmacogenetics Implementation Consortium. There is a series of guidelines for CYP2D6 drug pairs, and the one I'm showing here is for atomoxetine. And the heart of every guideline is really this table 2, which gives a recommendation table for genotype-informed phenotype. Now, had Ben been dosed according to this guideline based on his first genotype as an IM with an activity score of 1, he would not have been dosed differently than anybody else and still had the chance of developing these adverse drug reactions. With the guideline being as an activity score of 0.5, he would clearly have received a lower dose, and this reaction could have been prevented. So I think this is an excellent case of how pharmacogenomics can really help to guide individualized drug therapy and prevent these reactions. Now, for star nomenclature, this really shows or gives an example again for Ben. The top line here shows you the 2 SNPs that are used to assign a star4 no function allele. The bottom line shows 2 SNPs that are used to have this star2 normal function allele. And the star designation for an allele is really just a different way of saying haplotype. So a star allele or haplotype essentially really gives you the information of all the different SNPs that are sitting on the same chromosome together in a cis. The bottom part here shows you the SNP that was found in addition on that star2 allele, now making it a star59. So this haplotype is clearly different, and this is why it receives a different star number. Now, 2D6 allelic variation is really something I could talk hours about, and this is just a summary slide to show you how polymorphic this gene locus is. So right now there are over 390 SNPs and indels. PharmBar has captured and has organized into 163 distinct star alleles. And there's also copy number variants with identical gene duplication of functional and non-functional gene copies, and many rearrangements, hybrid genes between 2D6 and the pseudogene of 2D7, non-identical gene duplications in different arrangements and functionalities of these individual genes. So it's easy to imagine that genotype analysis of the gene locus can really be quite complex and challenging. Now, PharmVar is the go-to source to capture, catalog, and look up genetic variation and all these haplotypes and star alleles. So PharmVar is really a central repository for pharmacogene variation that focuses on these haplotype structures and allelic variation. And at the heart of this database of PharmVar is really the database that is free for everybody to use, regardless of whether you are in a research or clinical or commercial lab. You can use it and you can submit to it. We are working very closely with the pharmacogenomic knowledge base, and they in turn work very closely with CPIC with the goal to standardize all these star allele and variant annotations for these pharmacogenes. PharmVar members do not have access to any additional information. All information is available to everybody at the same level, but we are drawing our expert panels from the membership. And gene expert panels is really important for this community resource. So experts contribute to the resource, which we in turn bring back to everybody in the PGX community. So every gene expert panel has PharmGKB and CPIC representatives. Experts are typically coming from research, clinical, or industry backgrounds with international representation, and they help to curate the information as a gene is transferred into the PharmVar database, or as we are building new nomenclature for a gene. And after this is done, the panels are still helping with reviewing new submissions and recommend allele designations. So this is a group effort. It's not just one person behind these decisions of what gets a new star number. Now, what you see here is a screenshot of the CYP2D6 gene page. So every gene page looks essentially the same, and there are quite a few features of which I want to highlight some to you this morning. So first of all, you can download information directly from this gene page. However, many users are using our API to access and download information in a more systematic and efficient manner. Another really nice feature is that the variants are mapped to the genomic reference sequence, the transcript, both genome builds 37 to 38, and in the case of 2D6, also a legacy reference sequence, which we discourage using, however. You can also select whether you want the SNP positions displayed from the A in the ATG start codon or from the sequence start. You also do have a number of filter options, which allows you to select different displays or filter, for example, to highlight which allele has a particular SNP, do some searches, and also link out. We do provide CPIC clinical function assignments in this line for the core alleles. Now, a core allele is basically summarizing a bunch of suballeles, or in other words, all suballeles listed under a star number can be collapsed into a core allele, and the SNPs or the variants in a core allele either change an amino acid, have impact on function by impacting splicing or regulation. So the core SNPs are shown in this gray bar, and underneath we have listed all the different sub-alleles. We also provide evidence levels supporting a haplotype definition. And what's also really important is documents you can access through this page. There is a README document which provides important information for the gene, explains how the database or this information can be used, how you can sort and find the information needed. There is a document that provides information for changes we have made. And if a gene also has copy number variation, as is the case for 2D6, there is a lot of information in this structural variation document. Now, there is not enough time to really dive deep into what PharmBar is offering, but if you are interested in a particular gene or want to know more, I'm always willing to give individual or demos for your group. So just let me know if you are interested. If you click on a SNP, you will activate the variant window where you see annotations for the SNV per HGVS. Underneath, we also do have what we refer to PharmBar style SNV annotations, which in some cases are slightly different from those for HGVS. You also see here the positions for all the references listed in both count modes in one view, which can be really helpful. This bar allows you to select and quickly see all variants with this particular variant. And down here, you can link out to dbSNP and also find information for the frequency of the SNP, not the star allele, however. Another really nice feature is our comparative allele viewer, where you can graphically display the different SNPs in these different haplotypes, where it's very easy to see that this SNP, for example, here is present in a number of different variants. You can see which ones has an altered function and which ones are unique by this star symbol. And here, this just shows you how you can select different alleles of interest, but you can also select all alleles that have been defined. And here, that allows you, for example, to really see nicely that this particular SNP here is present in many other haplotypes, not just one. And so if you would, for example, not test for these SNPs here I'm circling, you would then assign this allele as a star 10 by default. But essentially, not testing these SNPs, you might miss out on some of these more rare variants, and some of these cause a non-function, the allele to be non-functional as indicated by this red triangle here. Some are decreased function, so it might not make functionally a difference whether you identify and discriminate it from a star 10 allele, and for some function is still unknown. So this again is just a good example of how complex 2D6 analysis is. If you are interested reading up a little bit more for PharmBar and our genes, please go to the publication tab where you can access these for free. And PharmBar nomenclature is really used across the field. Many clinical pharmacogenetic test reports use it. The Association for Molecular Pathology provides clinical testing recommendations using star alleles. The CDC-based pharmacogenetic reference materials resource uses star allele-based nomenclature to identify reference materials. I have already mentioned the PharmGKB and also the PharmCAT initiative, which allows you to use genotype and sequence data to create reports using CPIC guided recommendations. There are also tools that have been developed to call these star allele based diplotypes, which is really essential, especially if you are working with next generation sequence data. And as I mentioned many times before, really everything comes together in using these guidelines to individualize drug therapy and advance and avoid adverse drug reactions. And this is my last slide, just to highlight that NAT2 is coming to PharmVar. So this is currently housed in our website in Greece. We are curating this gene right now, and hopefully we'll roll it out later this summer. So we are very excited of bringing in more genes. And with this, I want to thank you for your attention, and I hope there are a few minutes for some questions left.
Great. Thank you so much, Andrea. We do have a few minutes for questions. I don't see any in the Q&A or the chat, but if anyone wants to put any in there, we have a few minutes.
I think Yoon has his hand up.
Sorry, I have to take a call. Rebecca, can you take over for me? I'm so sorry.
Yep. Hi, Dr. Yang, did you have a question?
Yes, can I just, do you want me to type it in or can I just ask?
No, you can just ask, go ahead.
Hi, Andrea, that was really interesting. So in the case you presented, Ben, I mean, he scores 0.5, but he acts like a poor metabolizer. So are you saying the 59 is actually like non-functional allele, so will be like homozygous almost?
Yeah, this is what we suspect, that star 59 allele just is not having the correct allele function assignment. There is very little published on this. And so when you go back to the publications, I mean, yes, it has decreased, probably severely decreased function, but in the absence of in vivo data, it is really very hard for these authors to put this functional label on it. And when you follow CPIC guidelines for function assignments, we need just more information, and we hope to really take all of Ben's information, and I think we have a second individual as well, and write this up so the function assignment can hopefully be changed. And I think this is a good candidate to downgrade the activity score at least to 0.25, or maybe even make it a poor metabolizer. But there are also substrate specific differences. And for atomoxetine versus some other 2D6 substrate, not every allele has the same level of reduction. So that is yet another kind of challenge with these function assignments. But I think the current value for this allele is really too high. This has very little activity.
Thank you.
Okay, and I don't see any other questions in the chat. So with that, we can say thank you to Dr. Gettig. We appreciate you joining us this morning.
Thank you so much.
And we will move on to Dr. Christine Cruz. And I think she's going to join us. There you are, Dr. Cruz. Hi. Dr. Cruz is the Director of Research Operations in the Department of Pharmacy and Pharmaceutical Sciences at St. Jude Children's Research Hospital, and the Director of ASHP accredited PGY2 residency in clinical pharmacogenomics. Dr. Cruz earned both her BS in pharmacy and her PharmD degrees from Rutgers University. She completed a pharmacy practice residency and clinical pharmacokinetics specialty residency at University of Kentucky Chandler Medical Center, and completed a fellowship in clinical pharmacokinetics and pharmacodynamics at the University of North Carolina in Glasgow. Welcome. She is a fellow of the American College of Clinical Pharmacy, founding member of the Clinical Pharmacogenetics Implementation Consortium, and serves as an author for CPIC guidelines. Her focus is providing tailored, personalized therapy to pediatric patients based on their germline pharmacogenomic test results, training the next generation of pharmacogenomic experts, as well as providing pharmacogenomic education to patients, families, and other healthcare professionals. So thanks for joining us today, Dr. Cruz.
Thank you so much. Thanks for the introduction. And I want to thank Dr. Dixon and the organizers for the invitation to speak to you today. So I'm going to be talking really today about how to make preemptive pharmacogenomics work. So the first session by Dr. Gadick was so important to she really kind of bridged the discovery and the understanding, information about variants and how there's a connection to drug concentrations. And so really, we're going to kind of take this one more step into the clinical realm and talk about how to make this work. Sorry, I don't know how to advance my slides here. There we go. I don't have any disclosures. So for preemptive pharmacogenomics, what we're really talking about is first understanding information about a patient's DNA and their genomics, and then using that information to design therapy or prescribe a medication. So I'm talking to you from St. Jude Children's Research Hospital, where we do have an institutional focus on childhood cancer. And for that reason, I have a slight oncology bent to my talk, but really we understand that preemptive pharmacogenomics really works for many classes of medications. But when we think about cancer patients, I mean, for a long time, we've understood that tumor-specific characteristics can be used to design therapy for patients with cancer. But for our preemptive clinical pharmacogenomics program, we really use information about a patient's germline DNA as well. So there's a lot of therapy recommendations that we can make for cancer patients, both for chemotherapy agents as well as a large list of supportive care medications that we can really individualize based on germline pharmacogenomics as well. So how can genomics really impact prescribing? Really, there have to be three steps that are solidly in place. And the first step is really what Dr. Gadick spoke to you about in the last half hour, and that's really understanding how a patient's inherited variants really drive enzyme function. And so that step really has to be solidly in place. And then from there, you really have to have really rock solid way to determine a phenotype from an individual's genotype. And so in the example on the screen, a TPMT genotype can help us determine the patient's TPMT phenotype. But then also equally important, there has to be indisputably a recommendation that clinicians can make from understanding a patient's phenotype. So really each of those three steps, there's a lot that goes into that. The work of PharmVar and their resources are really such valuable resources to helping us understand really the first two steps. And then it really takes clinicians understanding how to make those recommendations. And this is where CPIC guidelines really come in and play such a strong have such a strong impact as a resource for clinicians on making those recommendations. And so we can see that, you know, ideally, the most ideal way to practice medicine would be to have these first two steps in place before the patient even requires the drug mercaptopurine, right? So that you're not scrambling in real time, trying to understand a genotype and determine a phenotype, right? If we could have those first two steps in place, this is how preemptive pharmacogenomics works. So if we take a look at the literature, several groups have published their experience with implementing pharmacogenomics at their sites. And I have some of those references here on the screen, and there are some common elements that these groups have successfully harnessed to implement pharmacogenomics in practice. And the first step would be to select the medications that you're interested in targeting. The second step being to select the genes that are important for those medications, and then to select the test and the lab. And as Dr. Gadick really described to us, it's important to understand what variants are important to test and make sure that they're included in your test. Next would be selecting the patient population that are going to be receiving the drugs of interest. And then really an important common element is to form a multidisciplinary team that can really help design how this is going to work for your individual institution. And so each of these teams who have published their successful experience have really talked about understanding or sort of setting a threshold of evidence for actionability for a gene really has to be predefined and in place before you start returning genes. And so whether you base that on CPIC guidelines, which Dr. Gaedic spoke about, or the Dutch Pharmacogenetics Working Group guidelines, or the FDA Pharmacogenomic Associations, really your group has got to choose that a priori and really set those predefined standards before you start. Also looking at the literature, there have been many surveys that have been published that explore clinicians' knowledge of pharmacogenomics, their willingness to implement, and really maybe their perceptions and attitudes about the status at their own site. And so one recent survey that was published in the area of oncology really came out earlier this week. And this is from researchers in Australia who really focused on moving forward with implementing DPYD for fluoropyrimidine dosing and UGT1A1 for irinotecan dosing. And the results were published earlier this week, and the results are in 156 survey respondents in Australia, which largely were physicians and pharmacists. Just sort of assessing the status, 21% of respondents across Australia recorded that they preemptively test for DPYD at their site, where only 1% currently preemptively test for UGT1A1. But the results of this survey is really important because there were some perceived barriers that were collected as well as perceived enablers. So the results that were published really bring in the concepts from implementation science, which really look at barriers, which are things that may prevent the adoption of a new process or implementation, as well as enablers, which are features which really promote implementation or a new way to practice. And so at the top of the screen are the respondents. Again, these are in Australia. Their two top barriers to implementation of DPYD and UGT1A1 genotyping are lack of reimbursement and a perceived long turnaround time for genotype results, which is something that we see again and again with survey respondents. Whereas the greatest perceived enablers to preemptive pharmacogenomics would include resources at your site for education and training, because we know that more education of clinicians can result in more implementation. And also a dedicated program coordinator, such as a pharmacogenomics specialty pharmacist being available at your site. So if we kind of look at the first two barriers that came up in this survey, the first one was lack of reimbursement. And here in the US, we know that cost and reimbursement is often talked about. So the cost of pharmacogenomic testing really can be as low as a few $100s, and it's coming down every year. Whether or not insurance pays for pharmacogenomic testing really depends on the specific insurance and the policy. Historically, reimbursement has lagged as payers sort of waited to see about clinical utility. And so there was a great progress that's been made with the milestone happening in 2020, where Medicare policy developments really marked a step forward with the molecular diagnostic services local coverage determinations being established, which really defined a broad definition of actionability shown here in this definition with a gene-drug interaction that has been demonstrated to be clinically actionable as defined by either the FDA or CPIC guidelines. And this has really been a great step forward. And currently, there's also a bill working its way through the California Assembly, which is also addressing this in support of Medi-Cal coverage for pharmacogenomic testing across the state of California. So we know that as these policy changes happen, we know that adoption will continue to grow across the United States. So this is helping to remove one of these barriers. So the second barrier in this recent survey of clinicians is the perceived long turnaround time for genotype results. And this is where a preemptive model really takes this into account, because ideally with a preemptive model of pharmacogenomics, you've got several gene results in place before a drug is needed. And so this is really why preemptive is the most utilitarian way to go. And so toward that end, Dr. Gaedick already brought to your attention this recent publication by the Prepare research group in Europe. So as Dr. Gaedick already described to you, there were the Prepare study published this sort of landmark paper in Lancet in February of this year. So these were researchers across 7 European countries. This was an open label prospective crossover study where half of the patients received pharmacogenomics guided prescribing and half received standard of care. And for this first publication that came out, the primary outcome was development of a clinically relevant ADR that was related to the index drug within 12 weeks of enrolling. And the Prepare group really divided their recommendations based on pharmacogenomics into 2 groups, into those that prevented toxicity and into those recommendations that improved efficacy. And for this first publication, they really focused on the preventing toxicity outcome. And significantly, these researchers found that the result was a 30% reduction in the frequency of adverse drug events for the tested group with an odds ratio of 0.7. And so that's fantastic. Also along the way, as Dr. Gaedick really already pointed out, these researchers learned a lot about pragmatic and practical effects. They really found out a lot about how to return results, about how to broadly educate clinicians across this wide seven country study. So you know, as we continue to see results from this huge landmark study, this is going to be really this is going to help us to bring down some other barriers towards implementation as we learn more and more. So what I want to do is talk to you about what we've done at our institution, how we brought preemptive pharmacogenomics to all patients across St. Jude Children's Research Hospital. So St. Jude treats pediatric patients with catastrophic illnesses, and really our environment is great for preemptive pharmacogenomics because we do have one electronic health record that we use across all of our inpatient and outpatient areas, so we can really capture the outcomes that we see across our patients. So in 2011, we implemented our large-scale population-based protocol. We call it PGen for Kids, with the goal of preemptively introducing pharmacogenomic testing across all patients at our institution with very few exclusion criteria. So for PGen for Kids, we implement 14 genes to guide 50 drugs across multiple therapeutic classes, as shown here in the schematic. And the way that we've introduced our genes, we started in 2011 with CYP2D6 and TPMT really as our first 2 proof of principle drugs. And then really as the CPIC guidelines were published over the years, we really rolled out new gene drug pairs as CPIC guidelines were published. And so that now we have implemented 14 genes for 50 drugs, and we roll them out over time. So how does this function in practice? Well, I'll walk you through the case of what we would do for a patient, ZB, who's an 11-year-old boy with newly diagnosed AML, who's enrolled on a frontline clinical trial at St. Jude. So we have research nurses who meet with this patient and his parents early on in therapy to discuss enrollment on PGen for Kids. So then at his next blood draw for clinical care, he has a whole blood sample obtained for genotyping. And so what this first conference does, it does a few things. It helps us with educating the patients, their families about the importance of pharmacogenomics. It answers any questions or misgivings they might have about genomic medicine. And it really starts the dialogue and creates communication really directly with the patients and their families, which is a really important piece of implementing this. So how it works is we collect a blood sample from our patient, we genotype, and currently we use the Pharmacoscan platform for genotyping, which tests over 1,100 genes, but of course, we don't return all of those into the EHR. Currently, we put 14 gene test results into the EHR, and these are the ones with the highest level of evidence as based on CPIC level A or level B, which are the two highest levels of CPIC grades for evidence. We place them into the EHR, and then we carefully design clinical decision support alerts, working with our clinical informatics team, which are triggered from the patient's individual results in their EHR. And these, over the course of a patient's treatment, these alerts will help guide pharmacists and physicians and clinicians on what dose to order for 50 different medications. So how this works is early on in therapy, ZB will have these 14 genes reported in his EHR through PGen for Kids. And then if he does require ondansetron for antiemetic therapy, we can individualize that using his CYP2D6. If he does require voriconazole prophylaxis, we design his voriconazole dose based on his CYP2C19. And then if he were to require a procedure, we've worked closely with our anesthesiology team to work into the workflow, returning two genes, RYR1 and CACNA1S, for the choice of inhaled anesthetics. And along the way, if this patient would have a high-risk variant for any of the genes related to his therapy, then CDS alerts are already designed. They're waiting there. They present in real time in the workflow as the clinician is entering an order for one of these genes. Then those pieces are already there in place, and they're presented, and they're part of the workflow, and they can help really design the optimal therapy for this child for many therapeutic classes of drugs. So our demographics of PGen for Kids really largely follow the demographics of our institution, with a median age at enrollment of just under 9 years, and with the majority of patients being treated for cancer, with 23% of patients being treated for diseases other than cancer. And what's really exciting is that we're able to show in a real population of pediatric cancer and pediatric patients that with 14 genes returned, that 95% of our patients have at least one high-risk variant that would be used to design therapy based on their results that are already there in their chart. They're in place. And again, we've worked closely with clinical informatics to have all of those CDS alerts ready to help design their therapy based on those variants, which these patients have. And our results of a 95% incidence of having an actionable result really is corroborated by the PREPARE group, which showed that in their population of European patients with 12 genes returned, that they observed 94% of patients had at least one actionable variant. So this is really holding that, that it really becomes quite efficient to measure a panel of genes, because there's so much information that's returned that can be used for prescribing of future medications down the line in the patient's care. So with PGen for Kids, we the top drugs listed that have actionability in our patients are here, and these are the top 10 drugs listed by number of patients who had an order for each of these drugs, with our top 2 most commonly prescribed medications with actionability being ondansetron and ibuprofen, just because of their common use in our population. So how does it all successfully function? Really, it works very well at our institution, and it works very well because we collaborate with multidisciplinary clinicians around our institution, as well as education. We really pause and take a lot of time and pay a lot of attention to educating our clinicians, because we understand that more education for what how this is important and why it's important really translates to more buy-in and more implementation, so that therapy can be individualized for patients. and really revisiting back to this newly published, the survey results from an Australian cohort of clinicians, going back to what the perceived enablers for successful implementation was by these respondents. And really the two top enablers reported in this recent survey were resources for education and training, and having a dedicated program coordinator. And these are two steps that we found very helpful and really integral to our program at St. Jude. So we have a clinical pharmacogenomics program. It is definitely a multidisciplinary endeavor. We partner with the medical teams with each new gene that's rolled out. We absolutely partner with the medical team. So for example, when we recently implemented MTRNR1 for aminoglycoside therapy considerations, we worked closely with our infectious disease team to design the alerts and really understood what's the most important information to go into CDS alerts, what's the most important therapy change that should happen in a patient with this high-risk variant. And so that when the alerts do present in line in the workflow, that actually the prescribers are the ones that actually help design the wording, design the thought process that goes into the wording, and there's more adherence to the recommendations that are there. The other thing that we've done is every time we roll out a new gene and we introduce it for preemptive pharmacogenomics, we really take the time to educate. We educate our medical teams. We really talk to physician groups around our institution. We educate genetic counselors who might be tapped into to return or discuss these results with our patients. And then importantly, we educate all of our pharmacists across our pharmaceutical services department. So we created competencies for all our clinical pharmacy specialists around the institution, which really, these competencies really provide a framework for education and really ensure a level of understanding that each of our pharmacists can help interpret these results and talk about them and help use them in the course of patient care. Also at St. Jude, we run a pharmacy residency, a specialty residency for clinical pharmacogenomics. So we started this residency in 2011. We're in the 12th year of this residency, and what we're doing is training clinical pharmacists to really be the specialists who go out to another health system and really start a preemptive pharmacogenomics program from the ground up. And currently this year, we have an excellent resident named Dr. Rachel Stone. She's taken a position at University of Virginia in Charlottesville, where she'll go after completing her training. So our clinical pharmacogenomics program, besides myself, our program was really spearheaded and started by our former chair of our department, Dr. Mary Relling, who's had really such a profound influence on implementation of pharmacogenomics really across the country and internationally as well. Our coordinator for our clinical pharmacogenomics efforts is Dr. Serene Haydar. We have one resident each year, and then we also have a 0.5 FTE of a clinical pharmacist that also is on our team and helps to return results to patients. Also, we consider all of our clinical pharmacy specialists to be part of the program because each of them has demonstrated a level of competency and are really the ones who are out in each of our medical teams really discussing these results. And so as a measure of how we're doing with incorporating clinical pharmacogenomics into the workflow of our patients, we recently had the experience of reporting the adherence rate to our CDS alerts that appear in our EHR. So our former resident, Jenny Nguyen, performed a retrospective review for us. And what she reviewed was when an alert such as an alert for a patient with a variant in CYP2C19 who's prescribed voriconazole, she actually captured how many times these alerts fired over a 10-year period since we introduced PGEM for Kids, and then really looked at all the downstream events that immediately happened from that and really captured how many times the recommendation that appeared in a CDS alert were followed. And what we found was that over the 10-year period, there were over 4,700 alerts, which which appeared and were acted on. And of those, over 4,300 alerts, the recommendations were accepted and those changes to therapy were made for those patients. So that's a 92% adherence to pharmacogenomic prescribing recommendations when it's presented in the workflow in real time with these interruptive alerts that pop up. And so just to look at how this adherence breaks down, our top two adherence rates were for rasburicase for patients with G6PD deficiency and for thiopurine prescribing for patients with either NUD-T15 or TPMT genotyping, high-risk variants. And the breakdown is here, and really all of these are extremely high levels of adherence. And perhaps the lowest level, which is still quite high, is for ondansetron, where just about 50% of the recommendations were accepted immediately downstream. And when we went and looked at this, this is really because of a timing issue. So ondansetron often is started very early in therapy. And ondansetron often is started before a CYP2D6 genotype result comes back and is reported for a patient. Often at that time, the patient and the clinician are already comfortable with the antiemetic regimen as it's designed and maybe don't see a need to make a change based on a CYP2D6 result. But otherwise, these really largely are in place before a first dose of a drug is required, and then we see a very high level of adherence. And just to kind of benchmark that, so in contrast, in the literature, in the medical informatics literature, there have been publications which looked at drug-drug interaction alerts, you know, those things that pop up all the time in the course of your workflow. And really at one large academic medical center, Idris and colleagues really observed how often drug-drug interaction alerts were accepted or overridden. And in 1 year, there were, at this medical center, there were 16,000 alerts that were presented, and 15,000 of them were overridden. And this is for drug-drug interaction alerts. And so really a 95% override is really, we've really flipped that on its side. So with our CDS thoughtfully designed with our clinicians in mind, we've actually shown a 92% acceptance of our CDS alerts for pharmacogenomics. And so that just brings me to the elements that have worked and that are actually our enablers for our successful preemptive pharmacogenomics service. And that is that we have really designed resources for education and training across our institution, that we do have a dedicated pharmacogenomics coordinator who really has built relationships with each of the medical teams and really is out there really helping bring this to the forefront of how we care for patients. And then also we gave a lot of thoughtful consideration to how we implemented our CDS alerts. We worked closely with clinical informatics. We worked closely with each of our medical teams as we rolled out new alerts. And we made them as helpful and as useful as we can. And so our adherence rate of 92% really sort of shows that they are useful and are used in the course of patients' care. So our PGen for Kids team is a multidisciplinary team. I want to thank the many people that are shown on this slide, which help make it work at our institution. And I just want to end with the thought of the potential of personalized medicine, which really is getting the right dose of the right drug to the right patient. And so thank you for your attention.
Thank you so much, Dr. Cruz. You have one question in the Q&A, and then as how does your team deal with any pharmacogenomics variants with an unknown or uncertain activity outcome?
Yeah, excellent question. So we understand that this is a moving, a dynamic process, right? So we do have some genes where there is an unknown or uncertain function associated with a variant. And so in that case, we scour the literature, make sure that we really can't make a call that it really is uncertain. And we sometimes do have to have a class of phenotype assignment, which really says unknown or uncertain, or we won't be able to make a recommendation based on this variant. But what we do is we always leave room for as the evidence comes out of discovery labs, such as Dr. Gaedick's lab, Dr. Jun Young's lab, who's going to be speaking later in the session, as the discoveries are made, we have the room to actually, have a dynamic way to add that in to our workflow. In all of our alerts and in everything that goes into the EHR, we actually date and timestamp it. So it's understood that as of this date, when the recommendation was made, it's based on the information that we have at this date, and maybe at a future date. We do often go back, and as new variant functions are established, we do go back and we can change the phenotype across a whole group of patients with a certain variant or certain diplotype. And so that is commonly what we do.
Excellent.
It's an excellent question.
And Dr. Lee, you have a question?
Actually, I think the similar question. So I do have another question is, so do you know roughly how many patients can be covered by this strategy, like 50% or more than that?
How many patients can
benefit from this?
Oh, yeah, absolutely. So our data show that 95% of patients do have high-risk variants. And so the question is, have the opportunity to have a variant that is clinically actionable. So there are starting to be sort of real world counts coming out of then actually how in different settings, how many patients actually do receive a drug, not just in theory could receive a drug, but receive a drug. And we're actually working on those data with our group right now. We hope to have that published soon. I think 50% is a good, is probably a good level, maybe even higher perhaps.
Yeah, that's a lot. Yeah, thanks.
Thank you so much. I'm going to turn it over now to Rebecca Brand, BJC pharmacist and clinical specialist, to introduce our next speaker.
Thanks. We'd like to welcome Dr. Dave Kaiser, who is a professor and director of pharmacogenomics at Manchester University. He graduated from the Ohio State University College of Pharmacy in 1986 and completed a 2-year fellowship in therapeutic drug monitoring and pharmacokinetics at OSU. Prior to joining Manchester, Dave was a professor of pharmaceutical sciences at Ohio Northern University after being a research scientist at Burroughs Wellcome and Glasgow Wellcome. He has been a clinical PGX consultant since 2012. He has over 80 peer-reviewed publications, including being the lead author on 2 pharmacogenomics textbooks. He is a past chair of the American Association of Colleges of Pharmacy Pharmacogenomics Special Interest Group, and Dave was named a fellow of the American College of Clinical Pharmacology in 2017. In 2021, he received an AACP Innovations in PGX Teaching Award, and his current research is related to PGX and opioid use disorder. Dave also serves as a co-chair of the Pharmacogenomics Global Research Network Education Committee. And with that, we'll turn it over to Dr. Kaiser.
Well, thank you for the kind introduction, and thank you for the invitation to speak today about pharmacist competencies and roles in pharmacogenomics. So I think this is a great follow-up to the first 2 speakers, Dr. Gaedick and Dr. Cruz, and you'll see some connections there. I do have a disclosure. I am a consultant, as mentioned, for a couple of molecular testing laboratories that include pharmacogenomics. The objectives for this presentation include describing pharmacogenomics education in pharmacy, kind of a backstory to show where we needed to come up with competency statements for the academy to delineate pharmacist competencies and foundational genetic concepts. We're going to talk also about, mostly really about competencies in clinical pharmacogenomics related to something called entrustable professional activities. And then throughout this presentation, there'll be some examples that illustrate the pharmacist's role in clinical pharmacogenomics. So as a backstory, essentially, in 2016, the American Council for Pharmacy Education, ACPE, the accrediting body for schools and colleges of pharmacy, published their standards 2016. And it was the first time that pharmacogenomics was in the standards that made that subject matter a requirement in curricula across schools and colleges of pharmacy, and really in 2 areas: in the pharmaceutical sciences, where the genetic basis for really individual differences in metabolizing enzymes and transporters and then also from the pharmacology and pharmacodynamic standpoint. So really focusing on the basic applied sciences of pharmacokinetics and pharmacodynamics. And then on the clinical aspect, a requirement in education in pharmacy was to use evidence-based information across not just pharmacogenomics, but other areas to implement pharmacogenomics, and really in a context of efficacy, clinical efficacy, improving clinical pharmacotherapy, and then also in preventing or decreasing the risk of adverse drug reactions. So this was the first time that we saw this, and it really connects in a number of ways to information that we've likely all seen before. From the pharmaceutical sciences standpoint, when you look at the clinical guideline annotations through the pharmacogenomics knowledge base, there's currently 200, at least as of yesterday there were, and roughly 70% of those are pharmacokinetic in nature, and the others are pharmacodynamic. So that basic education that the pharmacist has in pharmacokinetics and pharmacodynamics fits well with the actionable annotations that are available in this resource, as far as pharmacists being able to connect that and then apply it clinically. And speaking of applying it clinically, on the clinical science side of things, in trying to improve clinical efficacy, we're aware of data, and this data is a little bit old now, but it's cited frequently, that patients don't respond to their first therapies often. And so across these different drug classes, we can see anywhere from 38 to 75% really failures in first-time drug therapies. And we get into the trial and error prescribing that, that is the standard now, right? And we want to move away from that. And then from the standpoint of decreasing adverse reactions, the Food and Drug Administration adverse event reporting system shows data. Now, this is not all adverse drug reaction. This is all adverse events. So it could be some other context. But we know that pharmacogenomics, we believe that pharmacogenomics can play a role in that. And certainly the PREPARE study showed that preemptive testing, at least, and utilizing clinical guidelines can decrease adverse drug reactions by 30%, as Dr. Cruz had mentioned. So when we look at the education over time, and I think this backstory is necessary to point to why we needed to come up with some more contemporary competencies across the Pharmacy Academy for Education. When we look at the second row, when we see the PharmD programs, in 2005, only 37% had presented pharmacogenomics in their curricula. And of those, 56% had at least a required component. In 2010, those increased to 97%, and of those, 94% were required. And then a subset analysis in 2019 that was presented, and of course, this is post the 2016 mandate to include pharmacogenomics. We see that we likely believe there's 100% across the 140 plus schools of pharmacy. Now, having said that, there's no requirements for certain contact hours or certain subject matter to be taught across the different colleges and schools of pharmacy. So we end up with a very broad and diverse content and contact hours. And you can see some of the hours that are listed on this slide. So, it may be a consequence of not having enough pharmacogenomics expertise to teach across all of the 140 plus institutions. And that's changing, and that's a good thing. When students get towards the end of their formal entry-level degree programs, there are advanced pharmacy practice experiences, and we see a number of these experiences at hospital or health systems around the country, some at colleges of pharmacy, and then some other opportunities also. But there really aren't enough as far as those of us that are in pharmacogenomics are concerned, because we really want more, right? And we want more opportunities for our students to have an entry-level minimal competency that can allow them to practice at a certain level to collaborate with interdisciplinary teams. So beyond the formal didactic and advanced pharmacy practice education, as Dr. Cruz mentioned, there are residency programs. And you can see on the left of this slide a list of those that I found through the ASHP residency directory. The American College of Clinical Pharmacy also has a directory of residencies and graduate programs. And these are probably the most patient-facing education for putting specialists out in pharmacogenomics, and they're very much needed. we actually would like to see more slots, and I'm sure everybody that's involved in these would like to see more slots and more funding for this education. And then other institutions have moved to provide graduate programs, master's programs, graduate certificates. Some have dual degree programs that allow the student to pursue both the PharmD program and master's in pharmacogenomics simultaneously. So we are improving in our education efforts throughout pharmacy, believing that we are responsible for this as a member of an interdisciplinary team. And now, what about those pharmacists that are already practicing, maybe graduated well before 2016 in the mandated education, or even afterwards when there was a varied education from institution to institution? There are a number of what are called certificate training programs. Typically, these are tied to continuing education, maybe 8 to 20 continuing education contact hours. And they're provided through different organizations like the American College of Clinical Pharmacy or the American Society of Health Systems Pharmacy or others. Some medical centers, Mayo Clinic as an example, some private entities. And then some of these programs incorporate something called Test to Learn, which is really out of Phil Lempe's group at Pittsburgh. And it's meant to get pharmacists to a minimal competency level. But the point that we're at right now is we've had a very diverse education in pharmacy, and it's through the formal institutions that are training student pharmacists and graduate pharmacists, and then also the pharmacists that are practicing. So we need to really focus in on competencies that could be applied across the profession. Now, these competencies certainly are probably, or I say certainly, probably, but are likely, I'll say that, a third term, somewhat consistent with what Dr. Cruz mentioned about competencies that they have at St. Jude's, but I'm sure there's also many differences. So in 2002, the first competencies in pharmacogenomics were published, but this was really pre the technical advances and the ability to apply pharmacogenomics clinically as we are today. And so the competencies were updated in 2017. But the academy, the pharmacy academy, that is, went to something called entrustable professional activities. And I'll talk about those with a little bit of detail coming up. But underlying the current competency set, which was published about a year ago now in April of 2022, are some foundational genetic concepts. And these are concepts that are beyond just pharmacogenomics and are meant to put the pharmacist in the position to, if you will, talk the talk and understand the nomenclature. And Dr. Gadick's presentation was so important in that context. And so these 6 competencies that are listed here as far as the foundational are 6 of the total of 30 competency statements. Now, we're not going to go over all those competency statements, and I want to talk about a couple that are on this slide. So the first competency statement is related to understanding the nomenclature and basic genetic concepts, understanding that pharmacogenes are genes and how they can be understood as other genes are understood. From the standpoint of pharmacists understanding, putting all the patient information together, now we have to think about the second competency statement where the genetic component is added. We're certainly aware of social and behavioral aspects such as smoking or alcohol use or other use, drug use that can impact patients' response to medication. But now the genetics need to be included. From another aspect is understanding genetic testing platforms. Dr. Gadick mentioned that in some cases where testing does not include rare variants, that the default return of a normal star 1, if you will, can be problematic. And so pharmacists need to understand that if there's variants that are not in, say, the coding region, that certain kinds of testing may not be adequate, and they need to be able to interface with laboratory folks to make sure what testing is done is going to match what they need for their patient population. And then finally, they also need to understand the legal issues related to genetic information, unlike other laboratory tests, which don't imply other context of other family members' information, but also understanding how discrimination can occur. And of course, the 2008 GINA, the Genetic Information Non-Discrimination Act, was very important. And pharmacists that work in different states then need to look at what the states are doing. For instance, it's this GINA approach has been expanded in Georgia and California and likely other states. So now I want to focus on the pharmacist competencies relative to clinical pharmacogenomics. There are a total of 24 of those. We're not going to look at all of those, but these are going to be couched in a couple different ways. One is in something I mentioned a minute ago, the entrustable professional activities. What these are our profession, the pharmacy profession's discrete and distinct expectations for entry-level or practicing pharmacists to apply in their practice. And so we have 7 different domains. We're only going to talk about the patient care provider domain. We're not going to talk about the pharmacy pharmacogenomics specialists who may be involved in implementation, but we're going to focus on the patient care provider. We're going to talk about 7 of these statements and provide some examples. The second couching, if you will, is in the context of something called the pharmacist patient care process. So you see the diagram here, and you see that the competency statements for clinical pharmacogenomics 1 through 14 are related to the idea of collecting data, assessing that information, putting together a plan, a pharmacotherapy plan as part of the overall patient care, implementing that plan, and then following up in an iterative process. And this really is meant to be applied in pharmacy across all practice settings, whether it's a community pharmacy, a regional medical center, long-term care, or academic medical centers. So let's talk about a number of these different statements. And the first one in the patient care provider domain is related to the pharmacist being able to identify PGX test results that are relevant to the patient's care. And how wonderful it would be to have this happen in a preemptive standpoint, as Dr. Cruz mentioned, but right now it's mostly reactive. And the patient medication list needs to be looked at in the context of what high-level evidence clinically supported drug-gene interactions may be present. And so on the left side of this slide, you see a panel of tests from a typical clinical panel. You see the gene, the genotype or diplotype, and then the phenotype that's presented. And so the pharmacist needs to look at this relative to their PGX testing program, what their laboratory provides, and what the patient's medication list is. And this goes beyond, say, the more, I guess, dedicated pharmacogenomics services. If you look at the right of this slide, you'll see a report from a direct-to-consumer company, and I'm not promoting any particular company, but this is a report that returned information on CYP2C19, DPYD, and SLC01B1. So this direct-to-consumer information also needs to be understood by pharmacists, and we've now seen an increase in patients who are taking these reports to community pharmacies because the pharmacists are accessible. And so the pharmacist needs to be able to understand relative to the patient's direct-to-consumer testing report how that may impact their therapy. So this is one example, or a couple of examples, where the pharmacist needs to understand PGX testing relevant to patient care. A second statement in this domain is the pharmacists need to be able to interpret information, right, and to translate information. So this slide shows an example of a diplotype of a star1 normal function, and then the RS4149056 no function star5 variant relative to SLC01B1, and really the statins and simvastatin as an example in the original guideline. So the diplotype star1 star5 is related to decreased function, and the pharmacist can identify these through using PharmGKB clinical guideline annotations, or going directly to the CPIC guidelines or Dutch guidelines, and then looking at the therapeutic recommendations from these evidence-based guidelines. And as an example here, an alternative choice of a statin might be desired, or simvastatin is going to be used, and let's use a dose lower than 20 milligrams per day. Now, having said that, this information may not always be as clear as some of the clinical guidelines provide. And so there needs to be a context that the pharmacist uses for the level of evidence behind any given drug-gene interaction. A third statement in the patient care provider domain, and now here we are into the assessment, as we were on the previous slide, frankly, of the information that may be provided. And this reaches all the way back to the pharmaceutical science education, where the pharmacist has pharmacokinetics and pharmacodynamic backgrounds. The panel on the left looks at a way that pharmacists can communicate not only to clinicians, but also to patients about drug exposure, not necessarily stating area under the curve, but just talking about exposure and relating that to the different phenotypes, metabolic phenotypes as an example. So if it's an ultra rapid metabolizer, for a patient receiving an active medication, under the green curve there, you see relatively little area under that curve, relatively little exposure. And that needs to be expressed to the patient and the clinicians to maybe relate it to drug inefficacy. And so that's one component. On the other hand, you can think about the poor metabolizer and under the blue curve and the increased exposure and the potential increased risk for adverse drug reactions. And then the pharmacist, from the pharmacodynamic standpoint, needs to be able to recognize that certain variants in pharmacodynamic pharmacogenes can result in less than optimal effect and may also alter the potency of certain medications. So these are, again, statements that are related to that pharmacist patient care process. Also in this domain and looking at that PPCP, the pharmacist needs to be able to assess where there are actionable drug gene interactions. And so looking at the patient's medication list and understanding that there's evidence-based gene variants that impact the response to the medication, the pharmacist needs to connect that, whether it's through using the CPIC guidelines or the Dutch Pharmacogenetic Working Group guidelines, or looking at the FDA label and looking at the PGX levels that relate to testing. And I think that we're all excited about the PREPARE study that came out in February. And this is the third time you're hearing now that almost 94% of patients in that study, and there's many other studies, and then the data that Dr. Cruz showed, that a very, very high percentage of patients carry a variant that can be related to some drug gene interaction. And so drugs for which there's guidelines that are related to these variants need to be identified as actionable by the pharmacist. And this is what this competency is saying that we expect for our profession to be able to do this, along with the other statements. Now, from a planning standpoint, in this context of competency statements, this statement says recommend pharmacogenetic testing when appropriate. Well, certainly preemptive testing would be ideal. And here's a good example. This is a patient that we saw a couple of weeks ago, and the patient was not having adequate pain relief. They were on meloxicam 15 milligrams a day. They were also on tramadol and acetaminophen, and the patient was failing, or we were failing the patient, I think, as far as analgesia support. And so we recommended testing. Now, this is reactive, of course, and wouldn't it be great to have this information up front? What we found out was relative to CYP2C9, the patient was a star 1, star 2, and that relates to the intermediate metabolizer phenotype. But when you look at the dosing recommendations, the evidence-based dosing recommendations from CPIC, you see that it's similar, or it's the same actually, as a normal metabolizer. So this meloxicam dose is really maxed out essentially for the daily dose for the tablet dosage form. But the real kicker and the real, I think, eye-opener here for the clinicians that weren't really as familiar with pharmacogenomics was the finding of the CYP2D6 poor metabolizer phenotype, and the fact the patient was receiving tramadol and not converting the prodrug to the active form, likely to provide analgesia. So this is a good example where reactive testing was okay, but why would we want to put the patient through this point when we could use preemptive testing? And that is a recommendation that can be made by pharmacists also. From the standpoint of implementing, this is an example where the pharmacist has to implement PGX guided care plans. And the blue arrow pointing to the right just points out an example where there was a 50% reduction in the fosphenytoin dose based on CYP2C9 poor metabolizer status via the CPIC guidelines. And so this is a way to further optimize drug therapy, here having included the genetic component, the pharmacogenomics. And then as a follow-up, the pharmacist needs to have the standard therapeutic drug monitoring associated with certain drugs like phenytoin, concentration monitoring, and looking at this patient. This was a patient that had a traumatic brain injury, and was really receiving fosmanogenic prophylactically to prevent seizures. And we can see the therapeutic range of 10 to 20, and the patient's concentrations were in that therapeutic range. So I think that this is a good example of how these competency statements relate to the pharmacist patient care process, and really in that domain of patient care provider as a member of a team. Okay, so I've been talking kind of fast, I think, but I wanted to get some time to talk about some of these other entrustable professional activity domains for pharmacists relative to the overall PGX competencies. So the interprofessional team member domain really speaks to the pharmacists as viewing themselves as a PGX expert. Now, having said that, I'm not talking about advanced training as a PGX expert. I'm talking here about entry-level, competent pharmacists knowing pharmacogenomics. Now, these competencies statements that were published in 2022 have not been adopted ubiquitously, but we see it growing, and we see more expertise, and we see just the whole field moving forward. And so as a team member and having some background in pharmacokinetics and pharmacodynamics and connecting that with pharmacogenetics, then we view pharmacists as being really in a good position to be educators. From the population health promoter domain, these competency statements relate to pharmacists recognizing different frequencies of variance in given populations. And if the individual doesn't have PGX test results, then thinking about how the information from the frequency of a population could be utilized and maybe hedge the pharmacotherapy plan towards something that would be better for the patient. And also understanding that from a implementation standpoint, which I wasn't going to talk about much, but understanding what populations you have that you have a need for pharmacogenomic testing in. From the information master standpoint, pharmacists have been trained in drug information, and the resources that are available in pharmacogenomics are now becoming greater and greater. PharmVar and Dr. Gaedick's presentation is one example. PharmGKB is mentioned by both the previous speakers. And so we have to use evidence-based information. And when we do that and provide that through guidelines or through primary literature to clinicians, it helps to build confidence in the use of pharmacogenomics. And so that's where pharmacists are being trained from that standpoint. From a practice manager standpoint, this is more on the operational level. As an example, a pharmacist in a centralized pharmacy reviewing orders that may come from an acute care setting floor, and maybe getting alerted to a drug-drug interaction and trying to decide then, or looking to make the decision as to whether or not that drug-drug interaction that's been alerted is clinically significant. Maybe there's a patient that was on a beta blocker and they were titrated to the appropriate dose, and that beta blocker is metabolized through the CYP2D6 pathway, and now the patient has a maybe paroxetine for depression added, and there's a drug interaction. But if the patient's already a poor metabolizer, then the pharmacist needs to understand the impact may not be as great as others might expect. And so that's a context for the operational standpoint for all pharmacists. And then finally, as we've seen recently, just 4 days ago, updates to the SSRI guidelines through CPIC, the Prepare group presentation or publication in Lancet in February. Pharmacists need to keep up with this information. So self-development in pharmacogenomics is critical, as it is for the entire aspect of a pharmacist's practice. But pharmacogenomics is moving faster than most other fields, I believe, at this time. So those are the other entrustable professional activity domains and some context for those. And what I'd like to do is finish with a couple other comments. First, I want to acknowledge the group that wrote and published the most recent update of the pharmacy competency statements. This was done in conjunction with pharmacy organizations, with the membership of the American Association of Colleges of Pharmacy, Pharmacogenomics Special Interest Group, and others. And so you can see this great group of individuals. You see these names all over as leaders in pharmacogenomics. Also, I want to mention that there's other resources for the roles of pharmacists in pharmacogenomics. For instance, the American Society of Health Systems Pharmacy has a statement on pharmacists' role in pharmacogenomics. And I think this is the second iteration that was published in 2022. And what's really nice about that document is it goes to great depth, but puts in context the general pharmacist practitioner with pharmacogenomics and also the specialists. And then finally, the NHGRI Inter-Society Coordinating Committee for Practitioner Education in Genomics, they supported the competency project that we undertook and are really there in a broad way. And you can see the citation there and the link to it. So with that, I will go ahead and end and thank you for your time, and I'll be happy to take any questions.
Thanks so much. That was an exciting talk. Of course, as a pharmacist, I loved hearing everything that you had to say and excited about pharmacogenomics and how it's growing. You listed quite a few certificate programs, which I think is very helpful for pharmacists that did not have PGX in school. Are there other resources that you would recommend or ways to keep up besides the consensus statements for pharmacists like that?
Yeah, I think that professional organizations are an important aspect of pharmacy. And we see ASHP, we see ACCP having these programs, but not just the certificate training programs, but also other content that's available. Certainly pharmacists should be directed towards the resources of information like PharmGKB, the CPIC website, and also PharmBar. Definitely, I think pharmacists are very in tune with cytochrome P450, so they can relate to PharmBar very easily. I also think there's another good resource for pharmacists relative to drug exposure. The Flockhart table from the Indiana University is another resource that's great. And I would like to say that all pharmacists are practicing at a minimal competency in pharmacogenomics right now, but that's not the case. And it's because we are on this learning curve. We're all on the learning curve. And I think pharmacy is, in my opinion, of course, I'm biased, I'm a pharmacist, I think we're leading the way in that effort. So I think that connection with area pharmacy schools is also very important.
Thank you. And I don't see any more questions. So we appreciate you joining us today.
Well, thank you for the invitation again. I appreciate it.
And going back a second, if Dr. Cruz is still with us, there was one kind of lingering question from your talk. I'll kind of pause a second and see if she's still with us.
Yes, I'm here.
Hey, there was a question about PGX testing and whether it was covered by insurance or patient paid. And are you able to share the cost of these tests?
Yes. So at our institution, we do seek insurance coverage if it's available, and if not, it's covered by institutional funds. It's not patient paid at our institution. So there are other sites that are implementing and finding ways to implement preemptive pharmacogenomic panel-based testing. And there are several models. So there is the self-pay model, which several sites are going to, and finding that those costs are really coming down. Even in the self-pay model, it's really just maybe several $100s to test a panel of pharmacogenes. And as I discussed, insurance coverage is starting to grow and take on and take hold. So that's even just a changing landscape.
And actually, we just had one other question pop up for you as
Excellent.
well. Let's see. She sees that you test for G6PD. Since this has disease implications in addition to PGX, how do you handle this? Do you have the patient's assent or consent? And do you require enzyme testing for actual diagnosis?
Yeah, such a great question. There's so many intricacies to G6PD implementation. G6PD is interesting for a lot of reasons, but one of them being that it's an X-linked gene, or it's located on the X chromosome. So biological males have one copy and biological females have two copies. So there is some implications for with genetic testing of this. We do occasionally have a patient that is phenotypic male, and we might return two G6PD alleles on it. And for that reason, we really had to be strategic. So when we rolled out G6PD, we understood that there are some implications, especially in our population, because at St. Jude, we have a pediatric population. So there are some people who have not entered puberty yet that may, it could be associated with Klinefelter syndrome, for example, which is an XXY phenotype. We had to pause, we had to partner with our genetic counselors. And that's why in my short talk, I didn't have a lot of time to talk about how valuable our genetic counselors are, but especially for G6PD, we did partner with them on how to return results. So we do get consent from every patient before we test. And we do have some notice in the consent about incidental findings that could happen. And this is one really big incidental finding with G6PD because it is located on the X chromosome. So that has been, a real big emphasis that we have on education, working with genetic counselors and returning these results. And then the other thing that's interesting with G6PD is there is a way to test with activity testing. And activity testing at our institution has a quicker turnaround. So actually we partner both G6PD activity testing with G6PD genotyping because neither of them are perfect. And really we found that the combination of using both of them really helps nail down a patient's true phenotype. So what we do in the course of our therapy, patients who are likely to require rasburicase will get G6PD activity testing as a one-day turnaround. It's returned that same day. It's done on site as a quick measure, but we know that it's not perfect and there's a lot of interferences with the characteristics of the blood sample that's used. So we draw a genotype and that's returned as soon as it can be returned. And then we kind of really solidify a patient's G6PD phenotype based on both of those. So there's just so much to think about with G6PD. It has been a really complicated one, but a really fun one to implement.
Yeah. Great, thank you so much. And I think with that, we don't have any other questions at this time. We're going to take about a 10-minute break. We'll resume at 9:50. So we hope to see everyone back in a few minutes. Hi, everyone. That was a really quick 10 minutes. So hopefully everyone is back on here with us and ready to go for our next speaker. I'll be introducing Dr. June Yang, who is a professor and endowed chair in pharmacogenomics in the Department of Pharmacy and Pharmaceutical Sciences of St. Jude Children's Research Hospital. His research program focuses on genomics-guided precision medicine for pediatric cancers, especially the pharmacogenetics of adverse drug effects and its clinical implementation. With childhood acute lymphoblastic leukemia as a model disease, his group is a leader in using genome-wide association studies to discover genetic risk variants related to a variety of leukemia treatment response and toxicity phenotypes, many of which have direct clinical relevance as described in his publications in JAMA, Nature Genetics, Lancet Oncology, Journal of the National Cancer Institute, and Journal of Clinical Oncology. Dr. Yang is the president of Pharmacogenomics Global Research Network, an international scientific society promoting pharmacogenomics-driven precision medicine. He is a recipient of the NIH R35 Outstanding Investigator Award, American Society of Clinical Pharmacology and Therapeutics Young Investigator Award, and the American Society of Hematology Scholar Award. And Dr. Yang is also a member of the Children's Oncology Group. Excited that you could join us today, and I will turn the floor over to you.
Thank you, Rebecca. Can I share my slides from my computer?
Yes, you can share from your screen. Yep.
Great, let me do that. And let me know when you can see my slides.
I can see the slides.
Perfect. Well, thank you again, Rebecca, and also for the organizer for inviting me to this exciting symposium. I actually learned quite a bit from the first few talks today already. So what I want to specifically describe to you are our work related to pharmacogenomics or therapeutic toxicity, and use that as a case study to illustrate the value of precision medicine in diverse populations. So I will not discuss off-label drug use. I do receive research grants from Takeda Oncology and AstraZeneca for work that's unrelated to this presentation. As a pharmacologist, we know that there's a general positive correlation between drug dose and drug response. Usually, the more drug you give, the more response you expect to see. However, there are cases for patients with exceptional either toxicity or drug resistance phenotypes. For example, individuals showing at the bottom, they receive very high dose, but little response. So that what would be considered as a poor responder. And individuals on the top here showing exceptional response at a very low dose, and oftentimes that's associated with toxicity as well. So what pharmacogenomics does is actually trying to understand the genetic basis of this inter-patient variability in drug response and or toxicity. So the ultimate goal of pharmacogenomics is to use genetic information to individualize medical treatments, and for the purpose of increasing effectiveness and reducing side effects. So as I mentioned already, my research lab here at St. Jude focuses on pediatric acute lymphoblastic leukemia, a drug that we often use called thiopurines. There are actually 1, 2, 3 different thiopurines currently used in clinical practice. All of them are structural analogs of the natural purine base. Thiopurines are essential medicine listed on the WHO list, and they are used for a number of different diseases, acute lymphoblastic leukemia, which I mentioned already. They're also widely used for immunosuppressive immunosuppressive agents as well, particularly in inflammatory bowel disease, Crohn's disease, and ulcerative colitis. For acute lymphoblastic leukemia, this is a very, very important drug because it's essential for the curative ALL therapy in both children and adults. It's a prolonged exposure. In children, usually you have to take this daily for up to 1.5 years, up to 2 years. And also that's also true to some degree in some subsets of adult patients with ALL. So myelosuppression is a very common side effect for thiopurines, both 6-TG on the top and 6-AMP at the bottom. So dose titration is done based on WBC and ANC during therapy, but it's very, very challenging. So for example, if patients experience significant toxicity, immunosuppression, and it's indicate that dose reduction is needed. But if you have too much dose reduction, you end up delivering less intense chemotherapy, and that will give rise to a higher risk of relapse. But if you do not back off on 6-MP dose, and you actually put patients at risk of excessive toxicity, treatment disruption, which will also eventually lead to high possibility of a leukemia relapse. So it's a very, very fine balance to strike between this efficacy versus toxicity. For those of you who are not familiar with the thiopurine, I just want to spend a little bit of time talking about the pathway that's involved in the metabolism of thiopurine. So this is actually a prodrug showing on the left. And once it gets inside the cell, it undergoes multiple steps of enzymatic mediated metabolism. The first step is for the mercaptopurine base to be added to the ribose to form, and also to be phosphorylated to form an intermediate for TIMP. And this is subsequently converted to TGMP, TGDP, and TGTP. So all three of these are nucleotides. They include the mercaptopurine base. They have the monophosphate, diphosphate, and triphosphate. The TGTP is the eventual active metabolite for thiopurine. And TGTP, because its structural similarity to GTP, it actually gets incorporated into DNA double strand during DNA synthesis. And because TGTP is not the natural base, it actually forms a bubble in the DNA double strand, and that recognized as a DNA damage. And the cell will try to repair it through a futile DNA repair process, and eventually the cell will recognize you cannot fix it, and this triggers apoptosis or cytotoxicity. So this is the way thiopurine works. And just want you to remember TGTP is the actual metabolite. That's important for thiopurine on both toxicity and efficacy. Many years ago, I think this is actually in the 80s, and the work continued into the 90s as well. It has been recognized that there's a major inactivation pathway for mercaptopurine metabolism, which is mediated by an enzyme called TPMT, thiopurine methyltransferase. So what TPMT does is that a methyl group to mercaptopurine form this methyl metabolites, MEMP. So the methyl mercaptopurine is completely inactive. It cannot cause all the activation and the DNA damage that I talked about in the previous slide. So the therapeutic efficacy of mercaptopurine is essentially the balance between the activation pathway going from left to right, which I talked about on the previous slide, and also the inactive metabolism pathway mediated by TPMT going from top to bottom. So back in the early 90s, several groups, including Mary Reding, Bill Evans at St. Jude, Dick Weishaben at Mayo Clinic, started doing sequencing of the TPMT gene, and they identified a number of coding polymorphism in TPMT, including the G238, G460, et cetera, et cetera. So those are later known as STAR2, STAR3 variants. And these variants lead to loss of enzymatic activity of TPMT, and they also cause a significant alteration in thiopurine metabolism. Why is this clinically important? Just to keep in mind that 6-MP is a prodrug. It can be activated onto TGN or TGTP, and it also can be inactivated by TPMT into methyl mercaptopurine. So it turns out that patients who are homozygous for the defective allele, which I talked about in the previous slide, they actually have no TPMT activity. They have essentially no conversion to methyl metabolite, which is the inactive metabolite. So all the 6-MP is now converted into the active metabolites. So these patients have excessive high level of TGN, and therefore they have excessive risk of toxicity as indicated here on the y-axis. But patients who are heterozygous for the TPMT deleterious allele, There are 50% sensitive, there are 50% normal allele, 50% defective allele. So they have an intermediate phenotype. They have intermediate risk of toxicity because they have an intermediate level of TGN or active metabolites. For patients who are homozygous for the wild type allele, so they have a much lower risk of thiopurine related myelosuppression because they have a average level of TGN and they have average level of TPMT mediated inactivation pathway as activation as well. However, you see that the patients with the wild type genotype, still 7% of them experience toxicity. So we hypothesize there must be something else going on driving the myelosuppression in patients with the normal TPMT activity. So a few years ago, such a patient actually came to our attention through one of my collaborator and longtime friends, Alan Yu in Singapore. So this little girl here in the middle, her name is Belinda. She's 5-year-old. She was diagnosed with the ALL at the age of 5, and she went to Singapore for her treatments, for her leukemia treatments. And Alan Yu was the attending oncologist for her at that time. So what's unique about Belinda was she actually had a very excessive sensitivity to 6-MP, one of the 3 thiopurines I talked about before. So on average, for Asian patients, you will see the tolerated dose of 6-MP fluctuate up and down during the course of maintenance therapy, which is time course is on the x-axis. So the dose usually hover around 50 milligram per meter square per day. But for Belinda, she was particularly sensitive to this drug to the point that within a couple of weeks, her WBC, which is the curve showing on the y-axis, dropped quite rapidly. And she was so sensitive to 6-MP with such toxicity to this drug, she actually had to be, her 6-MP had to be stopped because of this excessive infection related to the myelosuppression. And of course, for a child with ALL, you really cannot cure the disease without 6-MP. So Alan, you put her back on 6-MP, and as soon as she was back on 6-MP, her WBC dropped again, and this went on for quite a few months. Eventually, they figured out that her tolerated dose for 6-MP is only about 2 milligrams per meter square per day, which is much lower than average. And of course, the first thing they did was to test her for TPMT, thinking, well, she might be TPMT poor metabolizer, but turned out she's actually TPMT wild type. So we suspect something else is going on. In order to identify the genetic causes for thiopurine toxicity in patients with ALL, we actually performed a genome-wide association study to comprehensively look at all the variants in the genome, trying to understand what may cause thiopurine toxicity. So this genome-wide association study is a collaboration between St. Jude and the Children's Oncology Group with almost 700 patients. We genotyped about 250,000 variants. We also have a validation cohort about 400 patients here at St. Jude. So for those of you who are not familiar with the genome-wide association study, each dot here indicate a single nucleotide polymorphism going from chromosome 1 to X chromosome. And the y-axis is log transform p-value for the association between genotype and the 6-MP toxicity. So the higher the dots, the stronger association, the more important variant is for the phenotype we're interested, which is 6-MP tolerance. So as you can see, there are 2 dots above the horizontal line, which indicates the genome-wide significant threshold. The first one is on chromosome 6, is in the gene TPMT. So that's our positive control. We know this for many years. So the experiment worked. And then there's a second hit, which we didn't know at that time, is on chromosome 13 in a gene called NUDT15. And here just shows you the correlation between NUDT15 genotype and 6-MP dose intensity. So as you can see on the y-axis, so the patients with wild type NUDT15 variants, their dose intensity is around 90%. So they can tolerate the normal dose, no problem at all. But if you're heterozygous for NUTT15, you can only tolerate about 60% of the normal dose, which means about 40% dose reduction. But if you're homozygous for the NUTT15, we have 2 patients like that. They can only tolerate about 8% of standard dose. Again, a huge dose reduction because of the excessive toxicity. And this association is also validated in the replication cohort, as shown here on the right. And interestingly, this particular variant that I'm illustrated here is actually in the coding sequence in exon 3 of NUTT15. And now if you look at the combined effect of NUTT15 and TPMT, so the x-axis showing the genotype for TPMT on the top, NUTT15 at the bottom, y-axis is the dose intensity. So if you're if you're wild type for both the gene, you can tolerate almost 90% of standard dose. If you're heterozygous for TPMT or wild type for NUTT15, you can only tolerate about 70%, so 30% dose reduction. The other way around, 35% dose reduction. If you're heterozygous for both the genes, you can tolerate about 40% of the standard dose. And if you're homozygous for either one of the 2 genes, you can tolerate about 6% of standard dose. Again, excessive myelosuppression. What's really impressive to me was if you look at only these 2 genes, only 4 SNPs or 4 variants, you can account about 80% of the patients who require more than 80% dose reduction. So genotyping only 4 variants in 2 genes, you can capture 80% of the patients who are at most severe risk of myelosuppression. And this really indicates the clinical relevance of this finding. So I don't want to get into the biological details because it's already published. So NUTT15 turned out to be an inactivating enzyme for thiopurine. What it does is it actually converts the active metabolite TGTP to the inactive metabolite TGMP, so removing 2 phosphates from the TGTP metabolites. So because the patients with NUTT15, the coding variant in exon 3, which I talked about, they actually have no detectable level of NUTT15 enzymatic activity. Therefore, they cannot perform this inactivation conversion. They end up having a lot of TGTP, a lot of DNA incorporation of thiopurine, of thioguanine, and therefore they have lots of DNA damage, and clinically they manifest as excessive toxicity. So this is important because not only this is actually illustrated by our pharmacokinetic study as well. If you look at the active metabolite level in patients with homozygous defective allele, they are indeed much higher than patients with intermediate metabolizer status or wild type genotype. This is true for 2 cohorts, both in Singapore and Japan. So this is very important because now if you think about the way thiopurine works, so let's say x-axis is the dose that we give 6-MP, the y-axis is the active metabolites, and we have 2 different patients. One is wild type, showing the more 6-MP you give, the more active metabolites you accumulate. And the red curve is the patients with NUTT15 deficiency. You also see this positive correlation. However, at the same dose of 6-MP, you end up with much higher level of active metabolite, which is why they have more toxicity. But now if you turn this around, you say that I know that 2000 DNA TG mole per microdata DNA is the therapeutic target we're trying to hit. Instead of giving them the same dose, what you can do is just to give the normal metabolizer, the normal dose, and with the NUTT15 deficient patients, you just reduce the dose to a lower level such that you can achieve the same level of exposure to the active metabolite. So this becomes clinically actionable, which is exactly what we did or we have done here at St. Jude. Since 2017, we actually implemented we added NUTT15 to our thiopurine dosing algorithm. So now we actually perform NUTT15 and TPMT genotyping from the get-go. We received the genetic results before the first dose of 6-MP on day 22. And based on the genotyping results, we actually individualize thiopurine dosing accordingly. And this has the potential to reduce the thiopurine related myelosuppression without compromising therapeutic efficacy. So this is important from a population genetics perspective as well, because NUT215 deficiency is very ancestry or race specific. It's almost absent in African Americans or individual of African descent. It's very, very rare in European population as well, but it's exceedingly common in East Asian and South Asian. It's also relatively common in Hispanics or individual with Native American genetic ancestry. And this is almost the opposite to TPMT, which is a lot more common in Blacks and whites, but much less common in Asian population and also less common in Hispanics. So now if you look at TPMT and NUT215 together, you can see up to 27% of the population can actually benefit from TPMT and or NUT215 directed thiopurine dosing, indicating the importance of considering pharmacogenomics when give thiopurine to these patients. So since we have accumulated a lot of preclinical and also clinical data over the past several years, we have been working with the CPIC or Clinical Pharmacogenomics Implementation Consortium, which you heard quite a bit about on previous talks, to publish a major revision of the thiopurine guideline to include NUT215 together with TPMT. We also worked with PharmVar to come up with a nomenclature for NUT215 alleles, which will facilitate clinical implementation. And NUT215 testing is now available at commercial and academic clinical labs and registered in the genetic testing registry hosted by NIH. And actually FDA changed the thiopurine label, I think 2018, to include NUT215 pharmacogenetic testing results as well. So we started doing TPMT testing preemptively at St. Jude on our frontline ALL protocol. We've been working with the Children's Oncology Group to develop similar guideline for national ALL study protocol as well. Because NUT215 deficiency is very common in certain parts of the world, we've been working with the St. Jude Global to develop these guidelines and conduct additional research in Japan, Singapore, China, Hong Kong, Taiwan, Guatemala, and many other parts of the world to implement pharmacogenetic-based thiopurine therapy, at least for patients with ALL. So it turns out that NUT215 is highly polymorphic, and there are about 76 coding variants in this gene, and many of them are exceedingly rare, which makes it's very, very actually difficult to understand the therapeutic implication for this variants, because with the R39C variant, which I talked about before, it's very common. So we can actually do a genotype-phenotype association study with several hundred patients, identify the significant relationship between the two. But with many of the variants, as you can see, they are only occurred once, twice, or maybe a handful of times in over 141,000 individuals. So it's almost impossible for us to conduct genotype-phenotype association, even if I can capture all the kids or adults with acute lymphoblastic leukemia receiving thiopurine therapy. So we have to have a functional assay to actually infer the potential clinical consequence of these variants. So I don't want to go through the exact details because it's also already published. So working together with Dr. Fowler at the University of Washington, we came up with a high throughput functional assay, which go through like this. So we first come up with a library of all possible variants in NUT215, and we try to introduce this variant in a controlled fashion in a cellular model, such that each cell will only have one variant. And then we subject this library transfected pool of cells to a scalable phenotyping assay. For example, it could be the stability of the protein, could be some other cellular phenotypes that are directly related to this protein of interest. And we identify cells with either high or low phenotype. And then we quantify the variant effects by using massive parallel sequencing technique. So for NUT215, we'll end up making a library of over 3,000 variants basically all possible coding variants in this gene. We introduced this gene into the library into the pool of cells that I talked about, and we have two different phenotypes that we are interested. One, we want to look at whether the variant can affect the stability of NUTT15, and more importantly, we want to understand whether the variants can affect the cell's sensitivity to thiopurines, either 6-MP or 6-TG, at a single cell level. And we did a whole next generation sequencing to quantify the effect of each variant on either protein abundance, stability, or drug sensitivity. So this is the results from the protein stability. As you can see that each column here indicated amino acid position. And going from top to bottom, we show 19 different possible mutations at each amino acids. And the bar here at the bottom or in the middle shows the secondary structure of NUTT15. So there are definitely hotspots. So the blue dots indicate the variant that actually cause very severe effect on NUTT15 protein stability. The red dots are basically the same as wild type. So a few places here, and some other along this secondary structure show that they are particularly susceptible to mutation, because if you have a mutation there, you definitely destroy the protein in terms of its stability. And this is consistent with the drug sensitivity or thiopurine sensitivity score shown in the bottom. Again, quite a few hotspots that are very important for the sensitivity of the cell to thiopurine and to thiopurine drugs. So using this information, we actually came up with what we call an activity score, combining both the protein stability-based screen and also drug sensitivity-based screen. And each variant received a score considering those two criteria, and the heat map is showing at the bottom. And then we want to validate the score versus a thiopurine toxicity in actual patients. We put together a cohort of 1,700 patients receiving thiopurine either for acute lymphoblastic leukemia or inflammatory bowel diseases. And we identify 6 known variants, some of the rare, some of common, and also 5 novel variants, all of which are singleton. Going back to the comment I made earlier, many of the rare variants in NUTT15 are actually very low frequency. And we look at their correlation with thiopurine toxicity during their ALL therapy or for inflammatory bowel diseases. So what you can see here on the y-axis, NUTT15 activity score based on the functional assay that we performed for all 3,000 variants. So if the activity score show a very low number, they turned out to be all of them actually experienced severe thiopurine toxicity during ALL or IBD treatments. And for patients who have a very high activity score, they did not experience toxicity at all. And this is very different from bioinformatic prediction, either using CADD score or REVEL score, which essentially did not predict clinical relevance of NUTT15 variants at all. So if you look at thiopurine pharmacogenetics, TPMT was first discovered in 1979, and interpatient variability of that enzyme was described in 1980, and took about 10 years to actually more than 10 years to figure out the genetic variants driving the interpatient variability in TPMT activity, and also the interpatient variability in thiopurine toxicity. And this led to clinical implementation in 2000. So it took about 21 years to go through the entire process. But I think NUTT15 is a much more impressive timeline, because it was first discovered in IBD in 2017, and then in 2019, the GWAS that was done in patients with acute lymphoblastic leukemia. In 2017, we figured out the mechanism by which NUTT15 affected thiopurine toxicity, and 2017 was clinically implemented. In 2019, this went into CPIC guideline, and we figured out all the potential pharmacogenetic variants in NUTT15 in 2019 using the high throughput assay that we talked about. So I think this is a very, very exciting time for pharmacogenomics, not only because how much is implemented, but also how much discovery is going on in this space and how fast it can actually go into clinical practice. So there are many other genes that are cited in CPIC guideline, of which drug dosing alteration is recommended. And I don't have the time to go through the details. I think some of this has been described by previous speakers as well. So just to summarize, that pharmacogenomics is a very important branch of genomics, particularly in the context of precision medicine. I think TPMT and UT15 are very, very important pharmacogenomic determinants for thiopurine toxicity. Thiopurine dosing can definitely be individualized using these two genes, as I illustrated already. And currently, there are 13 drugs for which those adjustments is recommended based on pharmacogenetic factors according to the CPIC guideline. So with that, I will stop here. And I do need to thank individuals working in my lab, my collaborators here at St. Jude, particularly Mary and Bill Evans, and also Christine Cruz, who presented earlier today, and also my international collaborators who participate in the NUTT15 work and funding sources as well. So be happy to take any questions about what I described today. And thank you for your attention.
Thank you so much. We do have a couple of questions. The first question I'll ask, so it sounds like based on your research, do you recommend anyone that's getting tested for the TPMT gene, do you also recommend the NUDT15 as well so they can be interpreted together?
Absolutely. I think it's very, very important. So right now at the St. Jude, we definitely test both. I think many other places do that as well. People have made an argument before that because NUDT15 is more frequent in Asians, so they want to test this only if a patient is of Asian ancestry or maybe of his Hispanic ethnic background. But now we have evidence to show that even individual of European descent, they have the STAR9 allele is actually specific to the European population. So that if you take a race-specific approach in terms of deciding NUDT15 versus TPMT, I think you would have missed those patients.
Thanks. And then Dr. Neidig, I'll let you ask your question. She's one of our other hosts. She's going to ask her question.
Hi, good morning, and thank you so much for your really wonderful talk. My question has to do with HPRT. And as we know, this is an X-linked gene. It's associated with Lesch-Nyhan syndrome, which affects males. However, a young child may not yet be diagnosed if they have Lesch-Nyhan, or they may have a less powerful, if you will, variant in HPRT. Do you test for HPRT too? Does that influence the metabolism?
HPRT is absolutely important for thiopurine metabolism, especially for 6-MP. Is the very first step on the metabolism pathway that I mentioned earlier. So we have had patients, I can't remember if it's at St. Jude or maybe another COG institution, who were diagnosed with ALL with germline variant in HPRT. Yeah, it became very, very difficult to decide what to give to that patient. So we don't routinely test HPRT variant, or because the syndromic patients are very, very rare. So we are not, it's not part of our pharmacogenetic testing panel. However, at St. Jude, we do clinical whole genome sequencing. So these patients can be identified, but it's through a different mechanism. I hope that answers the question.
We have just a couple other questions. Have you ever encountered a situation where a patient has had a liver transplant but also needed azathioprine? Does the donor versus recipient pharmacogenetics impact tolerability?
Yeah, that's a very good question. It's not necessarily a huge concern in our patient population. Obviously, we don't have many liver transplant patients diagnosed with ALL. But I think for myelosuppression, it's actually the hematopoietic system or cells that are more important. So liver transplant is not a huge problem, but bone marrow transplant might be an issue, especially when it comes to myelosuppression, because they might have a different genotype in their hematopoietic cells.
And then one more question. Are there any other candidate genes that explain remaining variability after excluding NUDT15 and TPMT?
Yeah, so if you look at the GWAS paper that we published, TPMT explained about 20% of intrapatient variability, and NUDT15 about 24, so altogether about 44%. So we still have about 56% that are not explained. It's ongoing research. I don't know whether there's going to be a big hit like TPMT and NUDT15. I think it's more likely to have many other genes, many other variants with a smaller effects, but they add up. But when you consider them collectively, they might expand the remaining intrapatient variability.
Okay. Thank you so much for the interesting talk. And I will now turn it over to Dr. Julie Neidig, who's going to introduce our next speaker.
Thank you so much. Our next speaker is Dr. Ann Wu, who comes to us from Harvard Boston Children's. She attained her bachelor's in biology from MIT and then went on to get her MD at Harvard, and also later on did a master's of public health at Harvard. She has been at Harvard basically the whole time except for a short stint at Yale. And her area of interest is asthma and pharmacogenomics. So I give you Dr. Ann Wu.
Sorry, I just
think
have
you're
to
still
unmute. Am I
Yeah.
unmuted now? Okay, sorry about
Yeah,
that.
perfect.
Okay, so thank you for having me. And the really terrific presentations thus far have really shown how pharmacogenomics is being implemented in clinical practice already. And these talks, especially Dr. Yang's talk, give hope for asthma pharmacogenomics. We're much farther behind because asthma is just a very complex disease, but it's very common. And so I feel this field is really worth pursuing. So I'm going to start out with talking about giving some reasons why I think that asthma pharmacogenomics would be very important to have in clinical practice. And then I'll show some of the work that I've been doing to show our progress. So asthma is really common. It affects over 330 million people in the world. 10% of children in the US reported in 2021 ever having asthma. There are two major types of asthma medications. There are rescue medications like albuterol, which is a beta agonist, or there are controller medications like inhaled steroids, leukotriene antagonists, inhaled steroids, LABA combination therapies, and more recently biologics. But despite these effective medications for asthma, there were still 1.3 million ED visits for asthma as the primary diagnosis in 2021. And in 2013, asthma cost $82 billion in the US when we accounted for costs of absenteeism and mortality. So my first reason for rationalizing that precision medicine and pharmacogenomics for asthma medicines is really important is medication adherence. So anecdotally, underuse of controller medications for asthma is really common. So I'm a pediatrician at Boston Children's, and patients are not taking asthma controller medications as prescribed. So commonly I say, are you still taking, your Flovent? And they said, what Flovent? So poor adherence to inhaled steroids has been estimated to account for up to 60% of hospitalizations. And I'm going to briefly present a study here where our goal was to look at real-world adherence to the major controller regimens. So we looked at proportion of days covered, or PDC. So this measure looks at if a prescription is prescribed by the provider, does the patient then fill the prescription at the pharmacy and thus have it available at home? We don't know for certain if the patient took the medicine, but at least if they have it at home, there's a higher chance that they're taking it. So if a prescription was prescribed for 12 months, but the patient only fills it once, then they would have a PDC of 30 out of 365 days supply, which is a PDC of 8%. So a previous study showed that PDC of over 75% for asthma controller medicines is needed in order to have fewer hospitalizations and ED visits. So in our study, we just looked to see what percentage of patients were actually filling their controller medicines more than 75%. And as you can see, it was really low. So in gray, we see that for inhaled steroids, only 3% of patients who were prescribed inhaled steroids actually filled it more than 75% for PDC. Similarly, for ICS/LABA, it was 7%, and then leukotriene antagonists, it was a little higher, but still really low at 13%. So we concluded from this that adherence to controller medicines for asthma is really low. And I have a theory that part of the reason adherence to controller medicines is low is because some of those patients feel, and I hear this all the time in clinic also, patients feel like they don't work for them. And they probably are right some of the time. So we have national and global guidelines for asthma, but morbidity from asthma is still very high. So this raises the question of comparative effectiveness of controller medicines for asthma. So the goal of this study was to look at asthma outcomes among children with persistent asthma after initiating one of these 3 main controller medication regimens. We looked at the outcomes of ED visits, hospitalizations, and oral steroid bursts in patients because that's the major outcome I will describe in my pharmacogenetic studies as well. But so we found that individuals taking leukotriene antagonists and ICS/LABA were actually less likely to experience ED visits compared to individuals on ICS alone. This was actually not what was expected because most people had thought that patients on ICS/LABA would have the fewer hospitalizations, followed by ICS alone and then leukotriene antagonists. So there were no significant differences. Also, individuals taking leukotriene antagonists and ICS/LABA also were less likely to need oral steroids than individuals on ICS. So we actually, people might worried about unmeasured confounding. We did our best using propensity scores, but a little bit of unmeasured confounding could have been still resulted. But so we concluded that use of leukotriene receptor antagonists are associated with similar risks of asthma exacerbations. And we did conclude that in certain cases, even though most people guidelines at this point had thought that ICS should be first line and then leukotriene antagonist second line, that sometimes you could start with the leukotriene antagonist, and that's probably because effectiveness is variable. So precision medicine or asthma pharmacogenetics could have a role here because it could help determine which patient do we start on the ICS or ICS/LABA or the leukotriene antagonist. So another area of pharmacogenetics that could use some help, lots of people in the prior presentations have talked about using pharmacogenetics for predicting adverse events. So let's just look at 2 of the controller medicines, and they have their share of adverse events. So inhaled steroids have the side effect, the adverse event of diminished linear growth rate in children, adrenal insufficiency, decreased bone density, skin reactions, and cataract formation. And then leukotriene antagonists could have allergic reactions, chest pain, and neuropsychiatric symptoms. So again, having some tests to be able to predict who's more likely to have these adverse events would be helpful. So this was one study just looking at an FDA label change. So in 2009, FDA had a label change for leukotriene antagonists, and it said, neuropsychiatric events have been reported with singular. Instruct patients to be alert for neuropsychiatric events. In this figure, you can see that when the FDA label change occurred in 2009, use or prescribing of leukotrienes decreased in physicians so it's probably a combination of physicians prescribing less and the patients using less. But leukotriene antagonists are a very good medicine for most people. So if we had some genetic mechanism to know who is more likely to have those side effects, it could be beneficial. So this label change for leukotriene antagonists was associated with decreased use. So costs are also a big part of asthma medications. Asthma is very expensive for society in general, but the medications are expensive for families and patients. So this was the cover of the health section of New York Times a few years ago, and they profiled a family who spent $1,000 per year out of pocket on their asthma medicines, and their insurer paid an additional $3,000. And this is becoming an increasing issue as we have more expensive medications. I'll talk about the biologics later, but also patients are having to cost share more and more. So for this study, we looked at financial stress to see if we ask whether we just asked parents whether they had to borrow money from a friend or family member or a credit card or bank, or whether they had to cut out necessities for things like food, rent, or other basics in the past 12 months because of their cost of asthma care. And we found that the lowest income and the highest income were probably felt less financial stress, probably because Medicaid has patients have their medicines paid for them, but it was sort of this middle group that felt the greatest amount of stress. But in any case, it's striking to me that so many people had felt stress from this. So we concluded that asthma medications are associated with significant financial stress, especially for households living at less than 400% of the federal poverty level. And avoiding medicines that do not work but are expensive would be beneficial. One of the previous speakers showed a great slide showing that, right? If it doesn't work and it's going to give side effects, and then now I'm adding if they're also really expensive, it would be better to avoid. So I alluded to, so our newest class of asthma medicines are biologics. So they cost on average more than $30,000 per patient per year. Years ago, I looked at the cost effectiveness of omalizumab, which was the first biologic on the market. And to this day, it's still the least expensive biologic. And we found that omalizumab was not cost effective for severe asthma. It had a cost effectiveness ratio of over $800,000 per QALY, which is through the roof. And the cost effectiveness ratio are still in this range or even higher now. Okay, so I think I've given a quick background of why I'm really motivated for asthma pharmacogenetics, but is it possible? A couple of years ago, I tried to answer this question by assembling a diverse group of clinicians and researchers from the American Thoracic Society and then also from NHLBI, experts in precision medicine for lung diseases. And we had a workshop discussing all the benefits and potentials. And at the end, we concluded that existing biomarker tests that are available for lung cancer, COPD, asthma, and other diseases aren't as the biomarkers for asthma really aren't available for clinical practice. And we identified clear knowledge gaps of we really need to be able to efficiently translate biomarker tests to clinical practice. We need to be able to assess their cost effectiveness, and then also to ensure that they apply to diverse real life populations. So while progress has been made towards implementation of precision medicine for lung diseases in certain settings, we really need many more studies. We're much farther from what Dr. Yang and others have described today. So we concluded that it's the newer biologics that are directed towards this 10 to 15% of severe persistent asthma that actually makes precision medicine and asthma pharmacogenetics more important. I mentioned omalizumab, which was the first biologic, but then more have come onto the market since then, and they're really expensive. So knowing who is most likely to benefit from these tests and most likely to have adverse events from the other medications or even these would have great value. So before turning to genetic predictors of asthma medication response, I'll just talk a little bit about genome-wide association studies of asthma. Dr. Yang gave you a nice description of GWAS in general. But so there have been 26 GWAS for asthma so far. 18 are in European descent, 2 are in Asian, 2 Latino, 2 African, and 2 in multiple ancestries. So far, only 46 unique variants have been found for asthma, and 43 of them were in European ancestry. Vicente et al. In 2017 found that the sum of heritabilities of 38 SNPs that they looked at that time was 2.5%. And they estimated that another 12% variability could be found. But this is just in contrast to, I think Dr. Yang said, he presented that 4 variants in 2 genes could account for more than 80% of the highest risk of myelosuppression. So really pretty drastic, but there's still value here because asthma is so common. So we conducted a trans-ethnic GWAS of asthma in JIRA. So it's the Genetic Epidemiology Research on Adult Health and Aging population from Kaiser, Northern California. And then we conducted replication in the EVE consortium into Gabriel, a European consortium. This is the Manhattan plot. So the HLA genes here, this big finding here had been described previously, but we described this new locus in IL-1, RL1, IL-1, 8R1, and these SNPs replicated in EVE and Gabriel. And then we looked at mean mRNA expression of this SNP in airway samples. And the bar plots here show the log normal transformed expression values of this SNP in the airway epithelial cells from the asthmatic versus the normal controls. And we basically found that this SNP was associated with an 11% increased risk of asthma and is an EQTL for IL-1R1, reducing transcript expression in the lung. So our results overall were this region that I talked about in non-white ancestry. And then we found some, just like Dr. Yang was expressing the need for diverse populations, we found 2 genes that were so significantly associated with asthma in Asian populations in JIRA, but they did not replicate in EVE and Gabriel. And then we also found another gene that was significant, genome-wide significant in JIRA in African Americans, but did not replicate. So then just as a proof of concept, we used our GWAS findings from JIRA and put them into a polygenic risk score. And we did 2 polygenic risk scores, one using a standard approach where we only use the genome-wide significant variants. And then we did a lasso sum regression approach where we let all of the variants potentially contribute. And we did find that across multiple racial ethnic groups, there was an association with increased risk. But this is only a proof of concept study, and it's not, it wouldn't be available for clinical use. So now I want to turn to medication response. So this is a study where we looked at genetic predictors of inhaled steroid. This is just looking at FCER2, which is the gene that has been most consistently associated with inhaled steroid response. So it codes the low affinity IgE receptor, and it's associated with poor inhaled steroid response by altering the inflammatory mechanisms in asthma. So under a recessive model, the risk for severe exacerbations for subjects homozygous for the minor allele on inhaled steroids is significantly greater than the major allele, and heterozygotes on inhaled steroids in white subjects. So this figure, it's a little bit flipped. It shows the probability of no severe exacerbations is lowest in homozygotes for minor allele. So then this is another proof of concept study where we just took 2 SNPs in 2 genes that have been associated with inhaled steroid response. So the 2 genes are CRHR1, which is the corticotropin releasing hormone receptor 1, and then GLCCI1, which is glucocorticoid induced gene 1. So we combined these 2 SNPs in a predictive test of change in FEV1, so forced expiratory volume, using a Bayesian model. And we found that the test identified patients with good or poor steroid response with an accuracy of 66%, which is better than chance. But clearly these 2 SNPs and these 2 genes are not enough for clinical use, but it shows some promise. And then this slide shows work that we did in a GWAS of inhaled steroid response. So in this GWAS, we found that CAP methyltransferase 1 or CMTR1 was associated with inhaled steroid response in 2 populations. We then looked at mRNA expression data from GEO to evaluate expression levels of transcripts potentially involved in asthma exacerbations. And we can see here that the mRNA expression value is higher during exacerbation than after. So then we conducted a genome-wide association study of inhaled steroid response. So again, this was performed in JIRA, the study I showed with where we looked at just asthma as an asthma infection status. This one we're looking at inhaled steroid response, and then we did validation in Mass General Brigham Biobank and also a Rotterdam study. And we found that this top SNP here is in the global analysis, each copy of the minor allele was associated with a 1.73, 1.48, and 3.34 time increase in the hazards ratio of asthma exacerbations. And PTCHD4 encodes the protein patch domain containing 4 that represses hedgehog signaling, and this is upregulated in atopic asthma. So again, this shows some promise. So relatively few genes, relatively few genes have been found associated with ICS response. And one reason is even though some of these populations we're using are the largest available, we still don't have large enough populations given how complex asthma is. And another reason I think is that we're not accounting for age differences. So there's some indication that response to inhaled steroids varies depending on age. So I have a set of projects I called ADAPT, which stands for Age Dependent Asthma Pharmacogenomics of Treatment, to really just look at age interactions. So for this series of studies, we focused on 2 of the most commonly used classes of asthma medicines, so inhaled steroids and beta agonists. So one controller medicine and one rescue medicine. And then we measured beta agonist response based on bronchodilator response, which is a measurement of lung function before and after albuterol. And then ICS response, as I mentioned before, is measured based on ED visits, ED visits, hospitalizations, and oral steroid bursts while on inhaled steroids. So for this study, we made use of CAMP, which is the Childhood Asthma Management Program clinical trial that has longitudinal bronchodilator response outcomes from early childhood to young adulthood over a 13-year period. We plotted bronchodilator response with age while adjusting for sex and treatment group. The treatments were budesonide, nidocromil, and placebo. And then we found that in linear mixed models, age is associated with a 0.24% decrease in bronchodilator response per year. So it shows that there's that it makes sense to look at an age interaction. Next, because we also have GWAS data available in CAMP, in this analysis, we focus on SPATS2L SNP, which has been shown to be associated with bronchodilator response. So just looking at this SNP, and if here, just to orient you, we have age on the x-axis, and then y-axis is the bronchodilator response. And then we stratified by genotype. And we found that bronchodilator response varies by age, and it's also different by genotype. So we concluded that there are age-related differences, that SNPs associated with bronchodilator response in childhood may be different in adolescence and adulthood, and then genomic panels for identifying the most efficacious individualized treatment should probably rely on age-specific genomic markers. So now I'll show you some other studies within, some genetic studies within ADAPT. So first is a genome-wide interaction study, so a GWIS study of the interaction of age on SNPs on the outcome of inhaled steroid response. So the results of this age by genotype interaction study shows that here are the Manhattan plots. And so we can see that for the discovery population on top and the replication population on the bottom, the red line is the threshold for genome-wide significance at 10 to the minus 8, and then blue is at 10 to the minus 5. So what we found was these two SNPs, when we looked at the joint p-values, these two SNPs in these two genes, THSD4 and HIVEP2, they did meet genome-wide significance. And so these were our results. We found that THSD4 had a protective effect on exacerbation risks in younger asthmatics, the younger they were while taking on ICS. And previous studies have shown that this gene is potentially involved in regulating normal and abnormal lung function, angiogenesis, and airway remodeling. And then HIVEP2 has been suggested to contribute to asthma pathogenesis through its role in an NF-kappa B binding protein and regulates Th2 cell differentiation in responses. And it may work through glucocorticoid receptor activity based on mouse studies. So some promise here also. And sorry, I'm just losing my, okay, there we go. And then here is another study looking at age by gene expression interactions on inhaled steroid response. So we used gene expression data from CD4 positive lymphocytes in ABRIDGE, the asthma biorepository for integrative genomic exploration, which is an open access collection of subjects participating in genetic studies of asthma with gene expression data available. And then we use replication population in Puerto Rican Islanders as part of GALA, which is genes, environments, and admixture in Latino Americans. So they had provided nasal brushings for transcript sequencing. And the main outcome here was ICS response. So asthma control, this one was asthma control while taking inhaled steroids. And genomic associations were performed using regression of this score on gene expression with age in years as a covariate. And we found that age appears to modulate the effect of SMARC CD1 on asthma control with inhaled steroids. So next, to investigate whether SMARC D1 plays a role in the inflammatory response, as well as the anti-inflammatory action of corticosteroids in vitro. One of our collaborators, Chan Liu, did a knockdown of SMARC D1 in human lung epithelial cell. And he found that there was a significant increase in, did I not show this? Oh, this is here, sorry. And so they found that they found that there was a significant increase in luciferase activity relative scramble control in response to both IL-1 beta stimulation and IL-1 beta plus dexamethasone. So to us, this verified that SMARCD1 is part of the inflammatory response. And then we wanted to investigate the connections of SMARCD1 gene and its protein product. And so we did a search of the biologically relevant network for ICS response. And this shows that cortisol is a controller of SMARCD1, and that expression of SMARCD1 is related to the glucocorticoid receptor, nuclear receptor subfamily 3. So in summary, and so this is what we concluded that expression of SMARCD1 does interact with age and its association with asthma control and inhaled therapy. And so our conclusions are, my conclusions are, precision medicine for asthma is greatly needed. It really needed, it has great potential to improve clinical outcomes, prevent adverse outcomes, save money for patient health insurers and society. I think focusing on age will be important, and that's one reason maybe further advancements haven't been made, and also really focusing on race and ethnicity and having creating large populations is critical. And so these are the ADAPT team members, and then these are the PEAL team members who had done some of the studies earlier, the more health services research studies. So thank you very much.
Thank you so much, Anne, for this wonderful talk. We have one question in the Q&A, and she says, Dr. Chen, many times one sees children outgrow their asthma. Is there a PGX explanation for this, or is this one more immunologic environmental effect?
Yeah, no, it's really complex. I think that there is a or just a genetic effect on, there's clear differences between childhood asthma and adult asthma, and there are different genetic predictors of that. So that's definitely a role. And what I did not mention is that a major challenge for this field is the role of environmental triggers and environmental interactions that I did not even address, but that's a whole nother field too.
Indeed. I did my pediatrics training at Montefiore and Einstein, and we also noted that there was a day of the week effect on whether or not a child was brought in with asthma, and they were much more likely to come in on a Friday afternoon to spend the weekend in the hospital and give their parents some respite from care. Never got published, but it was a clear association in our minds. In any case, are there any more questions for Dr. Wu? Then thank you so much for your wonderful talk. And we'll go to our last talk of the morning. Oh, wait, sorry. Please go ahead. Dr. Yang.
Hey, I just have a general question. I thought was a wonderful talk. I know that there's been quite a bit of effort in terms of increasing diversity for asthma GWAS. I think Esteban Berger from UCSF has done quite a bit of that. I feel like maybe pharmacogenomics is a little bit behind in that respect. I wonder if you have any thoughts about that.
Wait, pharmacogenomics in general is behind in diverse populations? You mean, or just asthma?
Asthma.
Oh, yeah, no, I think so. Yeah, so Esteban is has been a great collaborator of mine. I think I think we just need more funded efforts. I mean, the area that there's one thing of clinical trials, recruiting patients, but then the area that I'm trying to expand more into is making use of the real life populations, the biobanks, because I think that's probably where we can recruit the much larger populations where we need, like the JIRA study that I talked about, that is a real life population. It's just really hard to get the sample sizes we need with clinical trial recruitment.
Thank you.
Again, thank you so much for your talk, Anne. And now we'll go to our last speaker of the morning, Dr. Lee. Dr. Lee is an assistant professor in the Institute for Informatics, or I2, and the Department of Pediatrics at Washington University School of Medicine. Dr. Fu Hai has received his PhD in applied mathematics, information science, and his predoctoral and postdoctoral training in the field of bioinformatics and computational biology at Harvard and at Houston Methodist Research Institute. And his research interest is in developing novel deep learning and artificial intelligence models of tissue and single cell omics data to predict vital signaling targets, pathways, and drugs to treat complex diseases, including cancers or Alzheimer. His lab has developed a set of deep learning and AI models for signaling network inference, and drug repositioning and drug combination prediction. His lab is also developing AI models to uncover the multi-cell intra and intercellular signaling communication in the tumor microenvironment for novel therapeutic targets and in inflammatory diseases. What I'd like to do then is turn it over to Dr. Lee.
Thank you, Julie, for the introduction, and thanks for the invitation. Yeah. So yeah, let me share the slides. Yeah, can you see the slides?
You're still yeah, now you're not yet in the right mode. So just switch the mode at the top.
Swap displays.
It's the, yeah, at the, you were actually there, and then you need to just switch the display.
Oh, what do you mean switch? Oh, okay. Let me see.
That's it. Wherever you went before, you had it in display mode, but then you just have to switch which display.
Got it. Let me share again. Yeah. Yeah. Now it's better, right?
Now, one more switch display. It says at the top and the left, swap displays.
Oh, okay.
Just hit that. There you go. Perfect.
Okay.
Thank you.
Yeah. Okay. So my name is Fu Hai. So assistant professor in the Institute for Informatics and also Department of Pediatrics, Washington University School of Medicine. And so today I would like to talk about some AI model for the integrative and intreatable pharmacogenomics data analysis. The reason, so first, graph neural network, GNN, is one top graph AI model that is the most popular one for network structure data analysis, especially for omics data analysis. I personally believe it's the best model for integrative, multicellular level data, multi-omics data, and also to interpret the omics data in terms for target prediction and single pathway inference. So, and then we can apply this graph neural network models and to like multi-omics data analysis and single cell omics data analysis for drug and drug cocktail prediction. So, basically, we don't need to emphasize this. So multi-omics data are being generated. So from like a genetic mutation, copy number variation, gene expression, methylation, microRNA, proteomics data, and also clinical data. All this kind of data are in large scale. Genetic have a lot of features, probes, and also gene expression, methylation, all kinds have many features. Put them together, it could be for one patient, it could be over millions of data points. So then there's a challenge. So we talk about a precision medicine. That means based on the personalized omics data, we want to recommend what are the best drug combinations for individual patients. However, the challenge for, I think, for both computational and experimental challenge from omics data to a target, it's basically a selection problem from millions of possibilities to 10. I mean, I randomly put a 10 there. But this is my feeling when I collaborate with biological or clinical collaborators. They always ask, say, hey, you have the omics data, or I have the omics data. Can you give me the top 5 targets, I can perturbate, I can validate them, or what are the real causal targets? It could not be like, hundreds of thousands, targets or drug combinations, because experimentally it's very expensive, time consuming to validate that. So this is the computer challenge. So usually the standard or basic analysis using, for example, fold change and logistic regression to identify the top ranked, targets. This is one way to do that, and it can, if with this threshold, to like usually to 2, 1.5, and we can always identify a large number of targets. For example, here in many figures, I know that, so they highlight some important proteins or genes. However, as you can see, there are thousands of them, probably hundreds of them. They didn't annotate them. So this is sometimes we know that. So people select, targets not unbiasedly, but also based on their some, knowledge, prior knowledge, or personal preference to identify some targets. However, the limitation of this is we don't know what are the functions of other top-ranked proteins genes, and also we don't know the signaling cascades or signal pathways among these top-ranked targets. So then we want to do using the systems biology. In other words, we want to integrate all the omics data into a large graph, that the large graph integrate all kinds of multi-level cellular signaling interactions, including the central dogma or the biology from DNA level to the gene expression level, transcription level, and also to the proteomics level. And the proteomics data will interact with different other proteins. The other proteins like transcription factors will come back to inside the nuclei, bind to like promoter or enhancer areas to promote some other expression or other genes. So, and also the genetic mutations and the methylation data work on the DNA level will also affect the activity of the proteomics data. So in another word, so it's possible right now we integrate all the known or prior knowledge of the intactome from DNA to RNA and then to proteomics data. And also we can put metabolism data there, because metabolism data is also playing important roles in many like neurodegeneration, diabetes, and all this kind of disease. And they cause, for example, some inflammation that regulated by the dysfunctional immune response. So, so put them together, we will get a huge graph, and then we can have the capability to integrate the multi-omics data at a different level. Then the question becomes, a problem becomes a computational problem. That means we need to, from a huge graph, each node on this graph represent different proteins or genes, and then their values are characterized by the the RNA-seq data, DNA-seq data, and also metabolism data. And then the problem becomes a subnetwork extraction. In other words, we want to prioritize or rank a subset of nodes, for example, ideally less than 50, with toward from millions, data points to 100 to 50 to 10. I mean, this is the final aim. And then also we want to, in addition to rank the nodes, but we also want to rank the interaction, the edges. So in another word, so like a fold change can also rank nodes, but they cannot rank edges. But the network biology or system biology, we can rank the nodes, but also we can rank the interactions among them. In another word, we want to identify a sparse, very sparse, signaling cascades from a huge graph integrating a huge number of data points from multi-omics data. So this is the purpose of the computational biology. So, and then we propose using traditional, instead of using traditional graph theory, so we propose to use graph neural network. Again, it's one of the best ideal AI model for data integration. So in a very general concept, the purpose of graph neural network is basically the input again is the graph, and each node have their own different features that, for example, characterized by using the multi-omics data. And one node represent, for example, a protein or promoter area. And then this graph, the purpose of graph analysis is to first to convert the node, the graph into a numerical space. Basically, all AI models is doing that. We call it embedding. We try to embed no matter a graph data or other type data, image data, or any kind of type data to a new numerical space. In the new numerical space that we expect the data can be, important. For that, important nodes, genes can be separated from non-important proteins because it's a supervised learning. For example, the supervised learning can be, for example, we throw in we have 10,000 control cells, for example, if using single cell omics data, and also we have 10,000, disease single cells data. So we want to separate the two conditions, and it's a classification problem. But in addition to that, we can also add in some other constraints. For example, we want to identify the proteins genes that can separate the two clusters best, but also we hope that these kind of set of important proteins also have higher fold change. So in other words, we can easily identify a set of targets that separate these two conditions, but we wanted also want to collect the most important one. How can we do that? So basically, this is the basic math of the graph neural network GNN. So that have two important components. The first one is you need to aggregate the neighbor nodes information and also combine with the given node and then update the new features. Again, it's an embedding problem. So every node have their own feature at the beginning, but after a few iterations, their embedding is mapped to a new data space, a new vector space, and then the embedding process can be generally, represent using this mathematical equation. And then, there are some quite challenges. So, for example, we proposed a self-attention-based graph neural network model for key target node and edge detection. So basically, after input graph, each time we want to remove some nodes iteratively, remove the not important nodes and interactions, and then until 3 or 4 iterations later, we get a small subnetwork with a small set of important targets and also a small set of interactions. And then we apply this model. We can ignore this math behind it. And we apply this model and compared with other models. As you can see, our model can achieve very good results compared with other model. So in terms of identify the important targets and also in terms of the classification accuracy. Yeah. And also, then there's another problem when we do that, because we found that in the singular network interaction, as you can see, there are intensive interactions among proteins. So that means the general graph neural network doesn't work well because the information when propagated on the graph, they will disappear to the local neighbors because each node probably have too many neighbors. So in other words, if this given node share their information to all his neighbors, then the information will be disappeared, will not significant at all. So to solve this problem, or we call it's a distance problem. In other words, we want to explore a longer distance and the interactions among network nodes in a very sparse manner, rather than averagely propagate the information on the graph. Then we propose integrate the transformer idea. The transformer is one of the best discovery in AI theory field. For example, the ChatGPT, every powerful models, not just for graph neural network, and also other kind of large language model, image analysis model, all using this transformer idea to get a better performance. The transformer idea basically is we ignore the direct interaction. We only calculate whether a node will affect another node purely driven by the model rather than their spatial limitation. But we need to put a constraint there to make sure that this node within 3 steps away rather than too many steps away. So in that case, we kind of balance the connection. Instead of direct connection, we expand the connection to 2 steps, 3 steps, but also their connection weights are not directly decided by the connection itself, but it's also depend on their kind of correlation. I mean, this is the basic idea of transformer. And then based on this, as we validate our model, we don't worry about the math. We validate our model in 2 Alzheimer's disease sets, as you can see, the last row. Our performance compared with all existing graph neural network models achieved significantly improved the classification accuracy. For example, we classify the Alzheimer's disease cases versus control, because sometimes not like a cancer, Alzheimer's disease, the genomic data don't have a big difference. So this is why we it's hard sometimes. So as you can see, accuracy for other graph neural network models is much lower compared to our model. So with this model, we can also reconstruct a network, in addition to the classification accuracy. Actually, that's not really what we want. We really want to do is we achieve good classification accuracy, but also we want to identify what are the important targets that can contribute to the classification. And another important thing I want to emphasize here is that here, for these models, it's kind of personalized modeling. In other words, so every individual patient have their own model, network model, because that's reasonable because different patients could have different, genomics changes, or in other words, a complex combination of, genomics data can cause Alzheimer's disease. But also individual patients may have a little bit of different in their omics data, or that. So in other words, we hope there's a convergence in the pathway, but also there's a patient-specific pathway causing or the Alzheimer's disease. So of course, because this model can be also used for the cohort level single pathway inference, we just need to do the ranking on the patient level or do the ranking on the population level. So we can do that, but at least this model can be applied to infer personalized single pathway, single targets. And as the same, there's a famous limitation of graph neural network is called the one hoop WL test. In other words, as I explained, if you just apply general graph neural network to a large neural network, it won't work because the information cannot be propagated to a long distance. In addition to using transformer idea, we also want to use K-hoop graph neural network. K-hoop means instead of each time, each iteration or each method propagation, you are considering not just one hoop. One hoop means one neighborhood. You also want to consider 2 neighbors, 3 neighbors at the same time. So, and then of course, the computation cost will be increased a lot. So, but we tried this K-hoop graph neural network. We have 2 papers published, and we found that 2 hoops or more hoops have better or much more improved power to analyze the graph data. So, and then we apply this model to interpret for some targets. For example, there's a database called DeepMap. They screened using CRISPR technology to perturbate a lot of targets on a set of cancer cells. And then say, okay, they say experimentally, these targets could be important for tumor growth. But they have the experimental data, they have omics data, but they don't know what's the mechanism. In other words, the mechanism still unclear how these targets interact with each other and causing the tumor growth inhibition. And then we apply this model to different cancer cell lines using the multi-omics data. Again, it's multi-omics data using the Bayes graph, the same. So basically you can put a different omics data and then try to infer what's the best probability signal cascades like this. For example, these red nodes are in different lung cancer, pancreatic cancer, and breast cancer. The red nodes are the experimentally identified important targets, and then the rest are important targets that predicted by our model. In another word, this model can explain using omics data, multi-omics data to explain what are the potentially key signal cascades that the individual targets interact with and to control tumor growth. Yeah. The importance of this, again, this is one kind of aim, but another aim is we want to do is in addition to individual target screen or individual drug prediction, we also want to predict drug or combinations, whether we can perturbate or inhibit multiple targets on the signal graph and then get a better synergistic effects. So, and also we apply this model to medulloblastoma. It's one type of brain tumor in in children, and there are 4 subtypes of medulloblastoma, and in addition to the venous subtype, sonic hedgehog subtype, for group 3 and group 4, there's no clear genetic biomarkers, and we don't know the central mechanism behind these 2 subgroups. However, these 2 subgroups exhibit a worse clinical outcome. In other words, there's no good treatment, and there are higher metastatic rates, and also there are much more boys than girls in these 2 subgroups. We don't know understand what are the what's the underlying mechanism and signal targets, and then we apply this model to identify the potential signal pathways in the again, this is in the sub-cohort level rather than individual patient level. And then this is what we some network observed that in the male and females, they do have different signal networks. And also as you can see, the different color indicate the signaling could be from a methylation data or gene expression data. They are different. And the green are the annotations of these targets, say which signal pathways, which kind of functions of this signal the proteins belongs to. Yeah, and then we found that, and in the male group, the large tumor suppressor kinase and and a few other genes in the G2M cell division get involved only in male group rather than in female group. Yeah, and of course, we don't have experimental validation yet because we are a pure computational lab. And but I just want to show that the integrative omics data analysis can really identify something could be interesting. So in addition to this is a tissue level omics data, but we can also, of course, to apply the AI models to the multi-omics data to the single cell level to understand the microenvironment, the signal interactions in microenvironment. For example, we are working on the tumor cell in pancreatic cancer because the immunotherapy doesn't work well in pancreatic cancer because there are a lot of stroma cells in pancreatic cancer. But also we also apply this model to identify some important signal interactions in Alzheimer's disease because Alzheimer's disease is also believed it's an inflammation-related disease, and the interactions between microglia, astrocyte, and neuron, and also oligocyte are important. So we want to using single-cell omics data to do that. So and then there are some existing models like CCC Explorer. This is also one tool I developed in the previous lab. And also there's NatureNet Satutalk, but they have some limitations. For example, they don't have, they didn't use graph neural network AI model because AI model can get better results. So they have limited capability to infer the key signal pathways, and also they have limited capability to rank targets and rank drugs. They don't have the ranking capability. So using our model, we can do that. This is our problem data. And so basically we developed all the previous model definitely can be applied here, but we specifically defined another transformer-based, but also network-based signal pathfinder model. The advantage of signal pathfinder model, because we want to solve the limitations, theoretical limitations of graph neural network. We divided the network, the huge graph neural network, into individual signal paths. And then we get scores for each individual paths using the transformer idea. In other words, we integrate the omics data, but also the spatial structure topology data of the graph, and then to rank each individual path signaling scores belong to the control condition and belong to this condition. In this case, we can fairly capture long distance signaling, the signaling cascades rather than limited the signal cascades to local. So using this model, and then we apply this model to Alzheimer's disease, we can we can identify some JAK-STAT Wnt cytokine signal pathways activated in astrocytes and microglia. Of course, we can identify the signal interactions between potential signal interactions between microglia and neuron, in addition to the within intracellular signal network, but this is called intercellular network. It's definitely important for, and you know, if, for example, if we use drug or drug combinations, in addition to targeting an individual like neuron or microglia, we can target on the interactions, you know, important targets. For example, one drug inhibit microglia targets, and one drug used to inhibit neuron signal target signaling, and then to block or perturbate their signal interactions. In another word, for example, in Dr. Davis' lab in WashU, they show that if they remove microglia and astrocyte, and the neuron will not be damaged, at least not will be not damaged so fast compared you put them together. So that means that the immune cells in the Alzheimer's disease really play important roles. But based on our preliminary data, we found that still in neuron cells, they have their own inflammation signal pathways are activated strongly. So in other words, we also believe that in addition to inhibiting the microglia astrocyte and inhibition the neuron inflammation signal pathway within neuron cells could also benefit the treatment of Alzheimer's disease. So yeah, so of course we can apply this model to pancreatic cancer. So in addition to, we talk about apply a graph neural networks to identify important targets, signal pathways within disease. Another important topic is also say whether we can predict what are the important drug or drug cocktails to inhibit these uncovered targets or uncovered signal pathways. Some targets likely have some drugs directly perturbated these targets, but for many cases, there's no direct interactions of these given targets and the drugs. So how about we propose some drugs that inhibit the downstream signal pathways of these single targets, or as I said, I'm also focused on the drug combination prediction, whether we can, you know, predict the drug combination targeting on different signal modules. Like here, we want to divide the network into different modules, and then we predict the best drug or drug cocktails targeting on different modules using drug target information, gene signature perturbation information, and drug disease association. And we integrate all this data into a graph we can rank. So what are the anti-inflammation drugs? What are the anti-COVID-19 drugs? And using the graph theory. So some models we developed before using graph neural network, we developed CGNet. We classify the top ranked drugs into clusters, and then turns out this drug cluster targeting different signal modules. The combination of these clusters can really get a better, synergistic effects, inhibit tumor growth in this study. And then 2018, and a lot of people starting to use deep AI model, but that time it's not an interpretable AI model. It's just a random standard, the basic layer by layer, like deep belief nets, DBA models. to predict drug combination, they can achieve good performance in terms of accuracy given experimental validated drug combinations. However, it's not interpretable. And we also, we also developed some models, but we quickly moved to interpretable, graph AI models. So first, we tried to integrate the pathway information to predict drug combinations, and then we can see we still can predict some drug combination effects, but we think it's still not good enough because the pathway level still not have high resolution, because in this model we model the pathway level rather than individual level, and the individual single cascades on these models. And then we started to, this is our recent work, and so we call it M3 net flow. So it's called multi-scale, multi-hoop modular graph AI model. And this is the preprint old version, and we have the new version of this. So basically we integrate multi-omics data and also drug targeting information. Of course, you can put a drug disease, all this kind of interaction data into one huge graph. And then we divide the graph into modulars, because if you don't divide the graph into modulars, you will cause a lot of trouble because the information will disappear. You cannot get good target ranking and pathway discovery. And then we integrate the multi-omics data and then let the information propagate on each individual module. And then we come down together globally and predict why two drug combinations works. And interestingly, this is, for example, in this model, again, not just interpretable, but also integrative, but also most important is interpretable. This, for example, tell us, for example, you throw in omics data of a cell line or a patient or a sample, and then we will highlight the important single pathways and also highlight exactly what are the potential important therapeutic targets, the red ones. And then using the validation results, we found that significantly many effective drug combinations have targets inhibiting different modules on these kind of uncovered single networks. And we validate this model using the existing validated drug combinations. We can find that a lot of effective drug combinations have these key targets and on this subnetwork identified by the graph AI model, and compare with the red ones have no less synergy than the cyan color have the strong synergy drug combinations. Yeah. So yes, we have a lot of models, and again, we are different from the great talks previously in other speakers. We don't have a lot of validation, but again, we are just a computer lab. So I'm interested in some collaborations always. So in a short conclusion, so in other words, so interpretable deep learning model, especially the graph neural network model, again, I believe is the best model for target ranking, single pathway inference, and the drug combination prediction, because it makes everything integrative in a meaningful biological way, but also it's a model can make the model results interpretable. In addition to give the accuracy of the classification, it also gives the important targets, important pathways, and important drug targets. Yes. And of course, theoretically, there are still a lot of challenges we are working on to get better models. And I want to thank my, some students here, as also my collaborators, yeah, and some funding support. Thank you very much. Yeah.
Excellent. Thank you so much, Fuhai. I'm looking for any questions.
The only question I had was, how do you see pulling the pharmacogenomic data from this? Because that's another form of omics. I was just on a study section for multi-omic research. Yeah. And a lot of the folks were putting in grants that pulled the pharmacogenomics data in addition to all these other omics.
Yeah, can you see the question again, Judy? Yeah.
Yeah. How do you see pulling the pharmacogenomics data from the genomics data in order to enhance the multi-omics data set?
How to put in the
You've got pharmacogenomics
Yes.
data that's within the genomic data, right? When you're sequencing a genome, you're going to pull in, there will be pharmacogenomics alleles.
Yeah.
How do you see combining that specific data set with the other omics data that you're studying to look at not only whether or not a tumor or a disease is susceptible to a specific drug cocktail, but also whether or not the patient will react poorly to that drug cocktail?
Yeah, I think that's a really great question. So basically, yes. So for the omics data, I think you have to use a disease versus control. In other words, you need to know, just like a fold change, which set of targets are important targets. And on the other hand, you have pharmacogenomics data talking about like drug targets, drug disease targets, right? That will also kind of a graph indicate which targets could be important for that disease. And then at the same time, which targets could inhibit that targets or the downstream. And then you rank, so which drug, as I said in these slides. So you need to use control and separate personalized or patient-specific sync network. Say, oh yeah, using sequence data, this set of targets or sync pathway could be important for this specific patient. On the other hand, drugs that which drug can potentially perturbate which set of core subnetwork, right? And which target or downstream of that target. And then you say, oh, this target could be effective, this drug could be effective. But on the other hand, if there's no drug have no any relationship with these top ranked targets or genes or network, probably they won't work, Yeah.
Thank you.
Yeah.
So I think we're at the end of time. We could get the continuing education CME link slide back up so people can scan that if they missed that at the beginning. I want to thank all of our speakers today. We learned today about how rare alleles can make a big impact. We learned about barriers to and enablers of implementation of pharmacogenomics, including education and program coordination and the importance of these. We learned new information on genetic variants and toxicity and medication response, examples such as thiopurine and asthma. We learned about the impact of ancestry and age on pharmacogenomics variants and their significance. And finally, we learned about using deep learning and artificial intelligence to predict drug targets and combinations. So thank you so very much, all of you, for participating. We look forward to having a fourth annual Pharmacogenomics Symposium sometime next year. And you guys have a terrific rest of your day.